Good morning to all present here. Today is the last day of this highly successful third West Zone Pedicon and 31st Mahapedicon. I, Dr. Manju Zaibhai, consultant pediatrician from Navi Mumbai, welcome you all on behalf of IAP Raigad. We will begin today's session with guest lecture on allergic rhinitis. As you all know, day by day cases of allergic rhinitis are increasing because of various reasons. At the same time, many new treatment modalities are also coming in. So to update us more on this topic, I hand over the screen to Dr. Dhanesh Wolvoikar. Dr. Dhanesh Wolvoikar is a consultant allergist and immunologist practicing in Goa. He is President IAP Goa State. He is IAP National Trainer in Allergic Rhinitis Training Module, Asthma Training Module, Under 5 Wheezing Module, CADE, that is Childhood Allergic Disease Education Module. I welcome you, sir, and over to you.
Yeah, thank you, Dr. Manju. And without wasting time, we'll go on to today's presentation, because in 15 minutes, or less than 15 minutes, I have to give at least some 10 to 15 tips to our practicing pediatricians from the allergist point of view, how we can tackle the allergic rhinitis in day-to-day life, especially those patients who are coming to you again and again. And it's all based on this particular guidelines from all over the world. So what is allergic rhinitis? Every one of you know very well. That one who's come with the sneezing and rhinorrhea from both sides, from anterior and posterior, and they give scratching if it comes on the posterior side. And every one third of the global population is infested, and most of them are not worried. But what we will go in detail in next 10-12 minutes is those who are worried and how we can help them and others also, to prevent them from becoming chronic. So that's where you have the nose block and congestion is a major symptoms. And how you know, I'm not going to go in detail about this, which will take hours to explain everything, but few tips here. So how you can know when you are in dilemma, when the patient doesn't come with the exact symptoms of allergic rhinitis, or if you're feeling, tell them to elicit some signs if they are having history, if they're having a block or itch in the nose. But they will have this allergic mannerism, the turning the nose to one side or stretching the nose, or they come with the typical face only, with the bluish discoloration lower or below the eyelids, which is basically because of the stasis, a dark circle here, or sometimes with the hypertrophied face like of your adenoid faces and all. And your adenoid hypertrophy is also a part of this allergic rhinitis only. And whatever examination you have to do, nothing much, just put your fingertip over the nose, and if you can see a hypertrophic pale bogey inferior turbinate, that definitely indicates to you that you are dealing with a persistent allergic rhinitis. In acute viral infections or acute rhinitis or viral rhinitis, you will get this as a pink color or dark reddish color one. So that's a difference. And one thing that you should know, that you are having a lot of patients in the pediatric population of the wheezing, they've got asthma also. And where you don't put your stress is this allergic rhinitis. Asthma patient have 80% of them have allergic rhinitis, and we don't usually look into this symptom because they also need to be tackled. And those who are having only allergic rhinitis, up to 40% of them will progress to the asthma in future. Specifically, those who are coming in the later half of their life, and not the early wheezers, those who are early wheezers, and then with the gap, and then again coming out with the allergic rhinitis in the adolescent group, they will develop in another 1 or 2 decades into the asthma. This is the allergic march, and it is basically because of the one united airway. The histopathology is same. Inflammation on the upper airway will give rise to allergic rhinitis, and later on the lower airway involved will give to the asthma. Another important issue that many times it comes to with a diagnostic dilemma also is comorbidities. They come with only with the comorbidity symptoms. The underlying mechanism is allergic rhinitis. So you get a headache constant, and it is basically because of the sinusitis. And if you go in detail, there is allergic rhinitis. There are sometimes a block and polyp. Polyp is nasal polyp is nothing but protruding of nasal or protruding of the nasal sinus mucosa into the nose with the underlying allergic mechanism. They may have a block, and the patient may come with the snoring or difficulty in sleep or sleep apnea, basically because of the block and allergic rhinitis. Fullness of ear may be because of eustachian tube dysfunction. There may be a redness in the eye or stretching of the eye again and again. It's also because of the conjunctivitis, which is inflammation has gone through nasolacrimal duct into the conjunctiva eye mucosa. Or of course, there are so many other things like speech impairment, failure to thrive, reduced quality of life. All these are there associated with allergic rhinitis. And those who are getting these symptoms again and again, patients or their parents will always ask you this question: will my allergy go or not? And most of the time you answer them that it will remain lifelong, basically because you are dealing only with one component of the treatment, that is pharmacotherapy. And you have never thought that this patient which will have the problem lifelong, maybe asthma in future also, requires all the other things. You sit with them and give the patient education and know what is the cause of them. So you need to see allergen avoidance is major important component along with irritants, and allergen can be traced and immunotherapy can be given to completely reverse this condition. And these have been recommended by ARIA guidelines, that is allergic rhinitis and impact on asthma, the major one which deals with allergic rhinitis in the globally. So let's see what are these allergens. The few allergens which you know, which will give rise to allergic rhinitis. One important thing is the house dust mite. And what is this house dust mite? And the most important culprit, up to 80 to 90% of your allergy, respiratory allergy, rhinitis and asthma is due to house dust mite in humid atmosphere, in the coastal atmosphere, like where the conference is going on in Alibag or Mumbai, in my place in Goa, and other places also. It comes to even in Srinagar up to 50-60%. So it's a most common organism. There are 3 types, and all 3 can be detected very easily by skin test or by blood test. And where does this organism? These are 1/4 millimeter length organism, which are not bugs, but they are cousin of a ticks, and they stay in a atmosphere where they like. That's a low where the humidity is high, and inside the fabrics that where they like, all in the pillows, mattresses, your teddy bear or soft toys and cushions and everywhere, all this everywhere. If you wash and dry this, then they will not survive. In olden days, when people used to stay on a cow dung floor, it used to have a protective mechanism and there were no mites. And now with the affluence of income, the house dust mite also there with all human beings wherever they stay, and the allergy also various other reasons the allergy is flourishing in this patient, and it is difficult for them to get rid of all this thing or getting the mattress cover, pillow cover. The ideal mattress and pillow covers are not available in India. They're available in abroad. In free market, they're available in India also. Or you need to have a washable pillow with putting the towels inside and wash them every 8 days, everything. Even you have to remove your cushions, you have to remove the soft toys, has to be boiled in a boiling water for 15 degrees centigrade for 15-20 minutes in order to get rid of it. Dehumidifier can help, but your air purifier may not help because the allergen, full house dust mite is not allergen. But there are allergens which are there in the pellets and all. They're very, very minute and cannot be trapped even in the air filter, which traps pollens and fungus and all. So the other important allergen is a fungus. Alternaria and asparagus is commonest one, and wherever there is a moisture, it grows. Moisture, fungus goes. And the most important place is your bathroom. And even if you clean this with your smell or whatever, acetic acid or vinegar and all, it doesn't go completely. Wherever there is a leakage, there is a fungus. Even outside on the dry leaves, fungus goes. And sometimes later on, this fungus goes totally inside of your sinuses and give rise to acute fungal rhinosinusitis and problems which cannot be easily can be treated. Yes, animal dander, everyone thinks it's a cause, but pet is more allergenic than dog, but both are not that much common in India. When but the pollens are common. And when the child grows older, when they grow outdoor, the pollens comes in the picture. Now, not every bright colored flower is allergenic. Now, what is allergenic is some grass pollens like this Cynodon, Dactylin, or Turva flowers, which are there all over the year, or some weed pollen like Parthenium, and very few tree pollens. So, which are the tree pollens? You have to get in touch with the allergy specialist in your area, and very few of them, 4 or 5 of them, may be allergenic. But what is more important thing, the patient may be allergenic to one particular allergens like your house dust mite, and in time to come, fungus may come, then one pollen, two pollen, over the decades this comes, and the life become horrible for even the doctors who want to treat them with a multiple allergen. But it is easy when you know in the primary stages. If one particular allergen can be treated very well by avoidance measures and up to very well extent by immunotherapy. So that's the reason early detection has been indicated and has been recommended by almost all the agencies in the world that are dealing with allergy. So how to detect them? Skin prick test is a gold standard. Very simple test. You have to just put a drop on a forearm of allergen or on a back and just give a scratch, which doesn't even give rise to pain in 2 years old child also, or even doesn't give rise to blood. And 20 minutes you can get a wheal, and that positive reaction can be done. But which antigens to put, you need little bit of allergy knowledge. That's the reason more and more pediatrician going into the allergy training and practice will be important, or else you get in touch with the allergist in your local area and deal with your patients. So if you don't know, can it be done by the blood test? See, total IgE is not very specific to allergy. Total IgE will be raised in many other conditions. So what at all, in case if you want, is serum specific IgE, and serum specific IgE can be tested by immunocap method. Please note that this antigens cost about 1,000 to 1,500 rupees. And if somebody is giving you 2,500 rupees by ELISA method or 200 antigen, it is wrong. There are many quackery things happening. So standard immunocap method by standard laboratory can be done. But which antigen you want to do, 4 or 5 antigen, again depends on your knowledge of allergy. Mites are the most important culprit, and then you can add some fungus or pollen. Fruits or your food is usually not related to allergic rhinitis. They don't give rise to, most of the time, it usually doesn't give rise to the respiratory allergy. So now if you find an allergen, if it's only one single allergen or maybe two, you can give immunotherapy. It can be very well be given above 5 years. There are specific indication for that. Each and every person who have a positive allergens have, or definite allergen can be found out. There is no need to give immunotherapy. Those who are persistent can be given and halted. You have to give over about a year, and then continue it sustained. It takes about 1 year for updosing, and then 3 to 5 years it has to be taken for a long-term remission or permanent remission also. Both oral and sublingual and subcutaneous are available, and each has merits and demerits. For oral, you don't have to come to the doctor's clinic. Subcutaneous, you need to come doctor's clinics usually twice a week and then decreases, but oral can be taken at home. Subcutaneous is better effective compared to oral. And this is about the immunotherapy. We will just give quickly about our management, what is already you all are doing, and where else required little bit extra thing, what is the manifest, what is the current evidence available at the moment. For all your mild cases, you need antihistaminics. Please remember that once the patient is moderate, severe, or persistent, that is continuous symptom, or moderate, severe, meaning sleep is disturbed, or school is disturbed, work is disturbed, they usually have block and require steroids. Among the antihistaminics in your armamentarium, for cetirizine to bilastine, there is a whole lot of choice, and anyone can be taken, but definitely not first generation antihistaminic, which has side effects. And second generation can be taken over a long period of time also. So if there is somebody who cannot afford, you can give cetirizine. Those who can affording, you can go higher ones also. Because of cognitive dysfunction, cetirizine, levocetirizine can be given in the lower age group, and the higher school age group, if somebody is affording, you can give fexofenadine. On over 6 years now, bilastine has come in the market. The side effect profile decreases from cetirizine to bilastine. Even your sedative effect decreases markedly. There are hardly any sedation from fexofenadine and bilastine, but the cost increases markedly. Topical antihistaminics like azilastine can be used as a rescue medicine and cannot be given for a long period of time. But most important thing is wherever there is a blocker like this, they do all the blockers, and most of persistent cases required steroid because it deals with all the parameters of inflammation. And mometazone and fluticasone can be given about 2 years. Fluticasone propionate about after 4 years. But more than which one, because they have a less bioavailability, this two, one of the term can be used. But what is important is how to use them. And tell the patient every time when they come to follow up with you, please demonstrate in front of you. It has to be directed towards the inner epicanthalus of the eye, inside towards the sinus opening, and not towards the septum. If you give towards the septum, there may be chance of perforation or sometimes epistaxia. Otherwise, they're very safe. In children, for 3 months, they can be very easily given continuously. You need again, then you need break and come again. But this patient who required it frequently required to be evaluated for allergy in detail with skin prick test and other methods. Montelukast deals only with the leukotriene antigen. Leukotriene is one of the parameters of inflammators and has got limited roles. It cannot be used for a long term nowadays. It will be recommended by ENT Association of India for 6 weeks and should not be, ideally should be used even for the less than that, because there is a box warning now in USA by US FDA that it can give rise to neuropsychiatric complications. And combination one, definitely it's not a standard one. There is no standard dosage. One is hydrochloride, other is sodium. So we don't know. Somehow some effects you get because of one particular, because most probably because of levocetirizine involved in it. Saline irrigation wherever possible. This neti is a fantastic thing. You can clear out the sinuses, especially before giving steroids in older children can be used. Other small word about this older preparation, they have gone with the time. Intranasal decongestant, very little role, should not be used over a long period of time. Oral decongestant like ephedrine, pseudoephedrine are banned, but unfortunately available in some syrups in India. Ipratropium bromine, intranasal chromas doesn't have a much role nowadays with the better modalities available. And in time to come, it is sure that biologicals are going to be the front line of the treatment, and they're going to be costly also. Omalizumab is already being used off-label in the chronic patients, but other biologicals are going to come and they're going to drain your pocket. So better use other methods and allergen identification early in your patient, and they can be given allergy-free life. Probiotics has been extensively studied nowadays. More and more market has been flooded with them, but what is shown promising result, but there's nothing specific that it is going to give a reversal of allergy as of now. Vitamin D has shown no promising data. So my take-home message for you is that for your treatment, use antihistaminics. You can use it over a long period of time also. Whenever there's a blocker, use steroids and very little leukotriene antagonist, that is montelukast, whenever required. Don't forget saline dosing injection wherever possible, and avoid triggers, that is both antigens and other irritants. Step up the treatment if not controlled, step down if it is controlled. And specific immunotherapy, don't forget, from anywhere, for all persistent cases, it can be used and can completely reverse your treatment and give you allergy-free life. I hope I have given a justice in 45 minutes. Thank you very much for patient hearing.
Thank you, sir, for giving that practical insight into allergic rhinitis management and useful tips for general practitioner. Thank you. Thanks a lot. Now we will move on to our next topic for today, that is urticaria in children. Urticaria or hives is an allergic skin condition responsible for lots of irritation in child and concern in parent. This is a type 1 hypersensitivity reaction caused by various agents like food, medicine, environmental allergen. To enlighten us more on this topic, today we have Dr. Vikram Patra. Dr. Vikram Patra is an associate professor and in charge of Pediatric Allergy Clinic, MGM Medical Institute of Health Science, Navi Mumbai. He has done fellowship in allergy and clinical immunology. He's also a contributor and national trainer for IAP Childhood Allergic Disease Education Module, and also trainer for IAP United Airways Under 5 Visas and CUF module. Over to you, sir.
Yeah, thank you, madam, for the kind introduction. And at the outset, let me thanks the organizers for giving me the opportunity to speak on the topic of um, urticaria in children. So, friends, why we need to know urticaria? Because we always think about the itching part, but here is the unmeasurable trouble what a child with urticaria has. It makes their life miserable by interfering with child's ability to participate in daily activities, disrupt normal sleeping patterns, thus causes emotional distress to the child. Negative, ultimately what happens, there is negative impact on the learning, cognition, school attendance, and academic achievement. And all this leads to major dysfunction within the family unit and substantially impact the quality of life as well as the family. So that's why this is the reason why we need to know. As we discussed, it makes the life miserable is one of the common cause of doctor shopping, and not only worrisome for patients, it is worrisome for treating doctors. So how to solve this then? By doing proper counseling, appropriate and timely investigations, and proper management. And for knowing these things, we need to understand the disease. Now, basically, let us go briefly, quickly, what is urticaria? Basically, urticaria is a condition which is characterized by development of wheals, angioedema, or both. Sometimes it can be both. And in 10% of cases, only angioedema will be there. Wheals, we know these are raised papules with surrounding erythema. And angioedema means subcutaneous swelling. And we know this is mast cell driven disease. On degranulation, mast cell releases histamine and other mediators, and they cause the ultimate symptoms. And is urticaria common? Yes, we do experience urticaria in our day-to-day practice. The lifetime prevalence for all urticaria is 8.8%, but chronic urticaria develop in 30 to 40% of these individuals. So as a pediatricians, we deal more with acute urticaria. But chronic urticaria, the prevalence in pediatric age group is also 0.5 to 5%. And it occurs in all age group, but as a pediatrician, we are a little lucky because it is more common in adults. And female prevalence for chronic urticaria, it is 2:1, and slightly higher. Whenever we ask about other allergic conditions, we ask about atopy history. So here it is also true. It is slightly higher in atopic population. So we have a classification we need to know while managing. We call it as acute urticaria if the symptoms, they last for less than 6 weeks. And we call it as chronic urticaria if the symptoms persist for more than 6 weeks. Among chronic urticaria, the cause can be known, and many a times the cause is not known. So the cause can be physical or non-physical, and we call them as inducible urticaria, which accounts to around 25% of the total chronic urticaria cases. In case, if case is unknown, then we call it a spontaneous urticaria. There is no triggering factor, and they contribute to 75%. And among them, 30 to 40% are autoimmune in nature, and whereas the bulk, the majority is chronic spontaneous idiopathic urticaria. And we have one more variant, which is acute intermittent urticaria. And this is very common in our practice. Now, coming to acute urticaria, which is common, always remember we deal with many viral infections, and infection is the most frequently documented cause. So out of our all acute urticaria cases, 40% is. So we need not jump into kya khaya tha, kya nahi khaya tha. So it is the infection per se. If there is history of URTI symptoms are there, then it is per se because of the viral infection urticaria has taken place. Other causes, we have NSAIDs, drugs which are common, NSAIDs. So even paracetamol can cause, but more common with ibugesic, what we use brufen, and what we use mefenamic acid, they are more commonly involved. Certain antibiotics are responsible. Many times we do vaccines. Vaccinology also can lead to allergy. Then food allergy. Many times it is correlated with some food, and if it is there, it is IgE mediated food allergy. But here I would like to highlight, common is pseudo allergy to food additives, not the food per se. The food additives, our kids, they eat junks and they contain food additives. Then not the least, we have insect venom and latex, though rare. Now let us go through some common scenarios what we get come across in our day-to-day practice. So she is a 10-year-old girl who came with history of fever and rhinorrhea for 3 days, developed this kind of rashes all over the body. She had been taking only paracetamol for fever. She had 2 episodes of febrile illness in last 1 year, and which were settled with only symptomatic medicines. So what from the symptomology we are realizing that she is suffering from viral URTI and she has taken paracetamol. So what are the possibilities as we discussed? So infection-induced urticaria is the most common, and sometimes we can look for drug-induced. Coming to the second case, this baby is 18 months old female baby, developed these rashes since 2 days. On asking, it was revealed that mother fed her chocolate cake. Baby has been taking cow's milk and wheat products in 6 months and 9 months of age respectively. Now when cake is involved, what we have? We have cow's milk, we have wheat products. So whether she is allergic to these things? No, because she has developed these symptoms at 18 months of age. So what is then it's the chocolate, which is again, this is because of the food additive. So these are the most common infection induced and food additives we should always consider in cases of acute urticaria. Now let us go through some more common scenarios. Master A, aged 11 years, develops papular pruritic rashes after coming from playing. One more baby, 5-year-old, develop rashes after taking hot shower. Master X, aged 15 years, develop after swimming in a swimming pool. So what we are getting here? We are getting some of the other trigger. So what are these then? These are inducible urticaria. Whenever you know the triggers, then these are termed as inducible urticaria, and they will keep repeating. So they falls under the category of chronic urticaria. Now we have symptomatic dermographism, delayed pressure urticaria, and cholinergic urticaria. These three are the most commonly what we see, and rarely we get cold, heat, and exercise-induced urticaria. Symptomatic dermographism, no other features will be there, and this is the commonest physical urticaria, and where there is generalized pruritus and wheals on friction, scratching, or stroking. Mucous membrane is unaffected. So angioedema will never be seen in this type of urticaria, and the treatment is simple to avoid frictions and loose clothing. Now cholinergic urticaria, this is little atypical, that's why I have posted these pics. Now these rashes are not typical of urticaria. These are tiny maculopapular rashes. So this tiny, they appear over trunk, neck and limbs, and they are triggered by exercise and emotional stress. So if a child comes out from playing, he will keep itching for a few hours and then it goes off. And it is common in older children. And the good part is that it resolves on its own within 1 to 2 years of age. Now coming to the chronic urticaria, when we talk about chronic, the bulk is chronic spontaneous idiopathic urticaria. What it means, though it is the bulk, but if extensive workup has been done and the cause is not correlated, and most of the time infections are to be blamed, UTI, dental caries, these are occult infections which are hidden, and type 1 allergy is extremely rare. Now chronic spontaneous idiopathic urticaria, I get references for allergy test of such patients. Actually, this is not type 1 allergy extremely, so allergy tests are not indicated in such cases. Pseudo-allergic reaction to food or NSAIDs are more common, and psychological and emotional stress. Now, yesterday I got a patient, adolescent girl, for last 1 year during this lockdown, she has started developing urticaria. So on asking, there were stressors from the school, and then always during monthly, she had started having this thing, and it was correlated with the menstrual. So any emotional stress, menstrual cycle, and during that time, the threshold of the body goes down and rashes appears. So ultimately, after knowing all these things, how to approach? So like in anything in our clinical practice, thorough history taking is important, and thorough history I have divided into causal and descriptive type. Now causal, we have to ask certain questions. Does it occur only and reproducible within 60 minutes of eating a particular food? Then we can have causal relation with food, and then you can think of IgE type of allergy, type 1. Now, does it occur after contact with an allergen to which the patient is sensitized? What we call it as contact urticaria. Could it be related to any drugs? Like mother will say, last time also that she had given Brufen, and this time also she took Brufen, the child developed. So this can be blamed. Are the urticaria lesions tender and painful or burning sensation rather than itchy? Urticaria, we always think itchy, but sometimes it may be painful or burning sensation. Then we should think of something else beyond that, vasculitis. They present to us with burning sensation. Does the skin show evidence of residual petechial and hemorrhage, purpura, or bruising? And these are also features of vasculitis. Then we have to look for other causes for infections as a cause. We have to ask about their respective symptoms. Descriptive, then time of onset of disease is very important, and number, frequency, and duration of distribution of wheals is very important. Now, this is a very good picture. Now, whenever there is inducible urticaria, the rash will disappear within few hours only. In chronic urticaria also, it will disappear within 2 hours. Most of the time in spontaneous urticaria also, within 24 hours, the rashes will disappear. But if rashes persist for more than 48 hours, we should think of arterial vasculitis. Now, remember here, when I'm talking about the duration, I'm talking about the duration for single wheel. Now, a child may come to us with urticaria for 5 days, 6 days, 7 days, but a single lesion, whenever they come to us, always we need to ask when this appeared and when it disappears. So you'll get most of the time, it comes, it goes from this place and it occurs in the other place. So it is fleeting. Then you are not worried. If it persists for more than 24 or 48 hours, then we should think of vasculitis. Then association of angioedema, associated symptoms of bone, joint pain, fever, abdominal cramps. Now, many a times what we get in our day-to-day practice, a child comes to us with acute abdominal cramp and we give symptomatic medicine and we send the child. Next day, the parents come and tells you that, sir, whatever medicines you gave, with that, the child has developed arterial rash. Is it because of the symptomatic medicine for the abdominal pain? No. Many a times, abdominal pain precedes the arterial rash, and it is because of the abdominal angioedema. So you should always keep in mind, whenever you are getting abdominal cramp without any other signs of or symptoms of GI infections, always think of and from the history, if some certain allergens or some triggering factor is there, always think of urticaria. Then family and personal history regarding wheals and angioedema, and induction by physical agents to know about the inducible. Now, diagnostic measures, basic test, basically we need to know differentials are blood count, CRP and ESR. Extended diagnostic workup should only be advised based on the history. A random test should not be done. And why we need to do diagnostic workup? For identification of underlying cause or eliciting factors, ruling out possible differential diagnosis. And these are the diagnostic tests. Commonly what we do in chronic urticaria, we do all these things. Thyroid antibodies we do. We go for to rule out for other infections. Then ANA and skin biopsy if the history is suggestive of. And allergy skin test is advised only if we are getting causal relation to a food item. So if parents are saying that after eating so and so food substance, the child gets allergy, then we have to go for skin allergy test. Now, many times you must have come across lab people coming and telling you about this urticaria panel test. So urticaria panel test is very costly. It around 8,000 to 10,000, and generally these are not recommended. And most of these panel, they contains serum specific IG for various food substances. And as we discussed, IG mediated food allergy is rare in chronic spontaneous urticaria, and whatever we get is because of food additives. So there is no unnecessary wastage of money. We can do skin prick test only if a link is found. Now, when coming to the treatment approach, what treatment approach we should follow? We should identify and eliminate the underlying cause, the avoidance of eliciting factors, tolerance induction, and ultimately pharmacological treatment, what parents need and what we need to give. So pharmacological treatment, when we are getting acute urticaria cases, we need to give a short-term treatment with H1 antihistamines. What do you mean by short terms? It can range from 5 days to 2 weeks to even 1 month also sometimes. And if it is chronic urticaria, we have to give continuous treatment. It should not be like that, just with episodes only. We have to give continuous treatment for at least a period of 3 months, and regular checkup is required. And never worry, all these second generation, they have a good safety data. They have data for 18 months also. But in physical urticaria, if inducible thing is known, then we need not give continuous treatment. Now, suppose a child, if it goes for playing and develops urticaria, just give antihistamine 2 hours prior to the activity. And when it comes to what antihistamines to be used, already Dr. Dhanesh sir has, in the last presentation, he mentioned about the antihistamines. The first generation antihistamines which are commonly used, hydroxyzine, the commonest brand what we use is Attenuation. And whenever urticaria comes in mind, prescriptions, Attenuation or hydroxyzine is given. So what they cause, they have anticholinergic effect and sedative action on the CNS. They penetrate the blood-brain barrier. They can also interfere with rapid eye movement and impact on learning and performance. So in acute urticaria, it will not matter a lot, but in chronic urticaria, it will definitely matter. So all these international bodies authorities on allergy, they strongly recommend not to use this first generation antihistamine. So second generation antihistamines are the first line symptomatic treatment, and they have good safety profile. And as mentioned by Dr. Dhanesh, fexofenadine, cetirizine, desloratadine, whatever you can use with the different profile. And the only thing in chronic urticaria is that it has to be taken regularly and using different antihistamines. Sometimes we prescribe 2 or more antihistamines together, which is not recommended. What about corticosteroids? Now, not only the histamine, sometimes other mast cell mediators like leukotrienes, cytokines, platelet activating factors, they are relatively refractory to antihistamines. So respond completely to a brief burst of corticosteroids. In such cases, if they are not responding properly with antihistamine, then we can give a short course, maximum of 10 days for prednisolone in acute exacerbation. And the dose to be remembered, like in allergic asthma, we use 2 mg per kg. The dose is 1/4. It is in the range of 0.3 to 0.5 milligram per kg per day. So remember, whatever dose you give for asthma exacerbation, you give 1/4 of that dose in urticaria. It will be sufficient. Other medications, montelukast, most abused drug. Here in urticaria, it can be used as an add-on drug, and its role is only limited to aspirin-induced urticaria and food additive intolerance. In other types of urticaria, it is not going to help. And many a times this combination is used. Never to use this combination. It's an irrational combination. And H2 antagonists, previous guidelines they used to say, but now recent guidelines they say no role of using ranitidine. Now my take-home points are: urticaria severely affects quality of life, so treat aggressively. Thorough history taking is must in urticaria management. In 60 to 70% of chronic urticaria, cause is not found. Investigation should depend on the history. IG-mediated food allergy is extremely rare, so expensive. So-called urticaria panel test must not be advised. Second generation non-sedative antihistamines are the first line of treatment. We have step-up and step-down approach in chronic urticaria. Never to use first generation antihistamines. Corticosteroids not to be used for more than 10 days. And not to use montelukast plus levocetirizine combination. Thanks again the organizers and the audience for your patient hearing. Over to you, madam.
Thank you, Dr. Vikram Batra sir, for this wonderful lecture. We got many new things to learn from your lecture, and I hope we will implement in our day-to-day practice. Thanks a lot.
Yeah, thank you, ma'am.
Now we will move on to our next topic, that is CT scan thorax normal and common abnormalities. CT scan is of the chest is one of the most important imaging modalities available to physicians. The advent of high-resolution CT scan of chest has led to its increasing use. While the chest radiographs are still very useful in our OPD practice, their utility is limited in diagnosis of lung diseases, especially the interstitial lung disease and pulmonary vascular diseases. So, to elaborate more on this topic, we have a pre-recorded video of Dr. Hiren Panwala. Dr. Hiren Panwala is currently working as a pediatric radiologist at Src Children's Hospital, Haji Ali, Mumbai. His areas of interest are pediatric neuroimaging and pediatric chest imaging. He has done fellowship in pediatric radiology at CMC Vellore, and he has various achievements and publications in his name. So I request the technical team to start with the pre-recorded video of Dr. Hiren Panwala. Thank you.
Good morning, everyone. I am Dr. Hiren Panwala. I am a pediatric radiologist at NHS Children's Hospital. And thank you, organizer, for giving me opportunity to speak on the topic of the CT thorax normal and common abnormality. So today we'll be going through under the subheadings. We'll start with the indications, then various CT scan techniques, followed by anatomy of the lung and metacinum, followed by common patterns of the Hrct lung, a few case-based discussion, and conclusion. So the indication of the chest CT in pediatric age group can be divided into acute conditions, in which these are the lung parenchymal indications, in which CT will be very useful in a case of complicated or persistent recurrent infection, or if we are suspecting any pulmonary embolism or infarction, or sometimes in a immunocompromised state, or for example, those patients under chemotherapy and you are suspecting any fungal infection. Amongst medicinal conditions, if you are suspecting any critical or major airway or vascular compromise, for example, in a case of high-grade lymphoma or ALL, they are known to cause airway compression externally, and in that case, CT can be very useful to quick diagnosis and starting early treatment. Among pleural and chest wall, if there is any drainage tube related complications or is there any persistent recurrent pneumothorax, then CT will be useful to identify the etiology. And CT chest is also useful for the chest trauma in acute condition. If it is severe enough and if there is suspicion of the vascular injury, then CT can be a one-stop modality. Moving on to the chronic condition, CT is useful in non-acute or chronic condition as well. In these lungs will be congenital lung malformation, which is the CT is the modality of choice as of now in the current literature. CT also useful in the diffuse lung disease, especially in the infancy as well as later age group, which itself is a separate topic. CT is also useful for the evaluation of the infiltrative or systemic disease like cystic fibrosis or evaluation of the bronchiectasis. And of course, CT can be useful for the staging and diagnosis of lung masses and metastasis. Amongst the medicinal conditions, CT is useful for the localization of the medicinal tumor and their probable diagnosis, as well as it is useful for the evaluation of the medicinal adenopathy. And amongst the pleural and chest wall, again, is there any chest wall deformity, or it is also useful for the assessment of the chest wall tumors. Now, the technique of the CT in pediatric age group is slightly different from the adult age group, that we use only single phase cut study, whether it is Hrct or contrast, and it should be based on the age and weight-based parameters so that we use as low radiation as possible, and we give good images also. And we should be thorough about this kind of other applications which CT have, like MIP and VR. What are these that we'll be seeing in subsequent slides. First of all, I want to highlight the difference between the Hrct chest and the CT scan. So here is the routine CT chest technique, that is helical scan. It runs from top to bottom and it acquires the information like in this slice manner, which is shown by this red arrow. But what happens in routine volumetric CT chest technique, that the data in between the slices, it is getting plastered and it is shown here, so that it gives you the volume averaging of the entire data, and you are not missing any information of the lung. In the contrary, in the Hrct technique, what happens that same way the scan goes from top to bottom, and you are acquiring the slices in between the lungs with a slice gap of 5 millimeter or 10 millimeter, at what you have provided. The advantage includes that it only gives information at that particular slice. So the architecture and the resolution is very nice. However, the disadvantage is that if any small nodules are there, less than 1 centimeter or something, that we can miss if it is coming between the two slides. However, the recent technology with multi-detector technique, what we can do that we can acquire this data, volumetric data, and we can reconstruct this kind of Hrct images so that we don't lose any information. So that's the basic difference between the routine CT and the chest CT, Hrct. So that's the visual difference between the routine chest CT lung window and the Hrct lung window. You can see that Hrct lung window has this kind of conspicuous vascular margins and the parenchymal architecture, which is better seen here as compared to this kind of blurry and hazy kind of parenchyma, which is seen on routine chest CT lung window. So that's the difference between those two. Then moving on to the common question which is being asked, that what are the indications of the Hrct? So the Hrct is useful for the assessment of the fibrosis, as well as it is useful in a case of industrial lung disease or a diffuse lung disease in infancy in children, which is a very hot topic or topic of research. Sometimes if you want to evaluate vasculitis or connective tissue disorders, Hrct is indicated. It is also indicated for the evaluation of the bronchiectasis. So these are the usual Hrct indications. Then these are the other software application that I was talking about, the MINIP technique. So MINIP technique is the minimal intensity projection technique, in which we are highlighting only the low attenuation density areas in the lung parenchyma. So those areas, like for example airway, cyst or bronchiectasis, they will be highlighted and they will be seen better. So this is very useful for the assessment of the airway. Then moving on to the volume render technique. So volume render techniques, it gives you the 3D appearance of the areas of interest. So that is very useful when you are assessing the cardiac structures as well as the aorta and the great vessels. This is particularly useful. Surgeons like this kind of image. And this is the image of the maximal intensity projection view. That is the MIP reconstruction image. So the advantage of using this thing is that it highlights the area which is having high density. So whenever we are using contrast, and these MIP images are very useful to assessment of the vasculature, aorta and pulmonary vessels. And it can be useful to differentiate between the tiny nodules and the tiny vessels. For example, here, these are the tiny nodules which are not continuity with the pulmonary arterial branching. So in that way, we can differentiate between the tiny nodules and the vessels. So that is the usefulness of this projection. So another common question which is asked is the indication of the contrastivity. So the contrastivity is used when we are assessing vascular rings or mediastinal or any lung or chest wall mass. It is mandatory to use contrast in a case of suspected pulmonary sequestration. If you want to evaluate or characterize the mediastinal adenopathy, contrast is required. Again, if you want to assess vascular structures or congenital heart disease, you can use the contrast. To establish the diagnosis of the necrotizing pneumonia or empyema, it is mandatory, or it is useful to use contrast in those kind of cases also. Then a few words about the virtual bronchoscopy. So the virtual bronchoscopy is the software in which it gives you the impression that as if you are going through the bronchoscope, and it gives you the endoluminal profile of the images from top to bottom of the selected area, and it gives you this kind of images. The color can be changed, and you can see that we are going across the lumen of the airway, and here we are seeing that this is the triangular areas of the vocal cord, and then below it will be the subglottic level, and then we can see the thoracic trachea with this cartilage from inside, and here is the view of the virtual bronchoscopy. So it is useful for assessment of the any endoluminal mucus plugging or foreign body. Now we'll move on to the next topic, that is the anatomy structure identification, in which we'll be talking about this mediastinum, thymus, lobes, great vessels, cardiac chambers, and the chest wall. So first of all, because you will be provided most of the time with outside axial images, I want to highlight to identify the structures on the mediastinum windows and as well as lung window in the axial plane. So this is the axial plane, first of all, in post contrast on a mediastinal window, and I'll be showing you the normal anatomy. So we are going from the top to bottom, from the thoracic inlet to the upper abdomen, and we are seeing that this is the upper part of the upper part of the thoracic inlet, in which the higher cuts are showing this kind of thyroid on either side and carotid vessels on either side of the thyroid, and these are the few necrotic nodes. This patient was a case of tuberculosis, and as we go lower down, we'll be seeing at the level of thoracic inlet this kind of clavicle which is coming on either side, and these are the chest wall muscle which are isodense or soft tissue, isosoft tissue density. This is the vertebra and the spinal column, and these are the ribs. As we go further lower down, we'll be entering the superior mediastinum. In the superior mediastinum, the anterior most venous structure will be the left innominate vein, which will be coursing in the retrosternal location, and it will join to the right side brachiocephalic vein to form a right side SVC. And at the same plane, we can see that these are the three great vessels: the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. On either side, we are seeing this kind of bilateral axilla, which is showing this kind of axillary nodes. These are some centimeter. We are also seeing this kind of paratracheal node, which are showing some calcification and necrosis, which is known to happen in the case of TB. As we go lower down, this is the section which is showing this arch of aorta, which will goes from the right to left side in a normal case. This is the SVC, which is pointing out here. Now, further going down, and we are seeing now we are at the level of pulmonary artery bifurcation. So here the ascending aorta will be seen, which is seen on the right side as compared to the pulmonary valve, and the main pulmonary artery will divide into right branch and the left branch, and on the right side we'll see this kind of SVC. Notice that now the carina trachea has divided into the right and left main bronchus, which is shown at this level. Below that we'll be seeing this kind of enlarged subcarinal node. And in the lower thoracic lung field, you will be able to see this kind of 4 cardiac chambers. The structure on the right side will be the right ventricle and the right atrium from anterior to the posterior aspect. And the structure on the left side will be the left ventricle and the left atrium. So usually the left atrium is the structure which is close to the vertebral body. And here we are seeing that enlarged right hilar node as well as the subcarinal node as is seen here. The esophagus will be lying somewhere here, which will be anterior to the descending aorta or side to side. So that's the normal anatomy that we are seeing here. As we are going lower down, then we'll be seeing the hepatic veins will be joining into the IVC, which will be seen as a circular structure in the liver, which will drain into the RA. And the further lower down, we'll be seeing this kind of crescent shaped spleen and the stomach. In this case of TB, we are able to identify some necrotic nodes in the lesser omentum and the perigastric space. So that's the normal anatomy about the mediastinum. And moving on to the lung window now. So lung window is useful for the assessment of the lung parenchyma and airway. We have seen the mediastinal window, which was useful for the chest wall as well as any mediastinal lesion, and also the soft tissue surrounding the chest wall, etc. The lung window now will showing from the top to bottom. So this is the nice circular trachea that indicates that the patient has breathed normally. As we go lower down, yes, we'll be able to see the upper part of the bilateral lobes. So that is the example of bilateral upper lobe. And then we further go down, and what we are seeing that this is the thoracic trachea, and these are the pulmonary bronchovascular bundle. So the bronchovascular bundle, which will contain a subsegmental bronchus as well as the pulmonary vessels adjacent to it. The bronchus should be equal size or less than that as compared to the pulmonary vessels. And as we go lower periphery, from central to periphery, the pulmonary vessels taper and they will become smaller and smaller. And in less than 1 centimeter area, we might not be able to see the pulmonary vessels. So that is completely normal. It's not abnormal thing. Then the trachea, it will divide into the this kind of right main bronchus and the left main bronchus. The right main bronchus will give rise to the upper lobe bronchus, as we are seeing, which will be horizontal in most of the cases. And then it will divide into bronchus intermedius. The bronchus intermedius itself will divide into the right main bronchus and left right middle lobe bronchus and the right lower lobe bronchus. So that's the way the bronchial pattern is there. And and here we are seeing that this is the lingular bronchus, which is divided from the left main bronchus, and this is the bronchus for the left lower bronchus. So here is the division of right and left side bronchus. Then when we come at the level of heart structures, we are seeing that the anteriormost structure will be the right middle lobe and on the right side, and the lingula will be the anteriormost lobe on the left side. And posteriorly, we'll be seeing this kind of bilateral lower lobes. And there will be a thin, this kind of linear structure which will come from posterior to anterior as we go up to down, and that is the major feature which is differentiating between the upper lobe and the lower lobe. So that's also a normal feature that we should not be mistaken it as a atelectasis or abnormal finding. So that's the normal anatomy of the lung. I hope that you would have gained some basic identification. Now moving on to the mediastinum. So the mediastinum is divided into the anterior, middle, and the posterior, as indicated by this purple color, this light blue color, and the yellow color. And how are the demarcation that we can best see on the sagittal images? So this is the sagittal image of the mediastinum, and this is the anterior mediastinum, which is superiorly bounded by the thoracic inlet and inferiorly limited by the diaphragm. It will start from the retrosternal margin, and posteriorly it will be limited by the pericardium. So this is the anterior mediastinal boundary, and it contains normally the thymus gland and the lymph node. And the pathology is that we all know that what can occur in this anterior mediastinum. Moving on to the middle mediastinum, it is the visceral compartment, and it contains the cardiac structures and the great vessels. Again, it is limited by the thoracic inlet superiorly and inferiorly by the diaphragm, anteriorly by the anterior pericardium, and posteriorly it will stop at the vertical line which is connecting each vertebral body 1 centimeter from its anterior margin. So that's the imaginary line that we have to draw. And these are the structures which will come into middle and visceral compartment, which contains the esophagus, airways, and the great vessels and the cardiac structures. Moving on to the posterior mediastinum. So the posterior mediastinum start from the posterior boundary of the middle mediastinum. That is the imaginary line that we have drawn from the anterior margin of the each vertebral body 1 centimeter behind, and posteriorly it will end at the posterior chest wall margin, which will end at the level of the lateral margin of the transverse process of the each vertebra. So that is, this area is containing the posterior mediastinum, and it contains the neurogenic tumor as the most common cause. Sometimes extramedullary hematopoiesis also can occur in this location. So now a few words regarding the thymus. So thymus is homogeneous in density, and it will be isodense to the chest wall muscle as we are seeing here, and it is quadrangular or rectangular in shape in the early infancy or less than 2 years of age, but it should not cause compression of the airway. Sometimes we do get indications that normal thymus compressing the airway, but that's not the normal case. On USC, it will be having this kind of dot and dash kind of appearance. As the child grows and the thymus gland involutes, and it becomes like triangular shape kind of structures. And the thickness of the thymus after 11 years of age, it should not be more than 1.5 centimeter. And it will be triangular in shape without any lobularity or necrosis. So that's the way normal thymus look like. Now moving on to some patterns of the HRCT. So the patterns of the HRCT can be divided into the increased attenuation or a decreased attenuation. So these are the example of the increased attenuation on the HRCT, and these are shown in the lung window, axial images, and we are seeing this is the classical example of the consolidation, which is showing homogeneous dense opacification of the entire lung parenchyma. On non-contrast study, you won't be able to see any pulmonary vascular markings, and it will have this kind of air bronchoram sign positive, in which the patent airway will be seen in the background of this dense opacified lung. So that is the example of consolidation. This is the example of crazy waving appearance, which shows interlobular as well as intralobular septal thickening in the background of generalized ground glass haze. So that is indicative of some sort of paved road. Here is the example of miliary opacity or miliary nodules, which will be seen as this kind of tiny pinpoint, less than 3 millimeter nodules, which are scattered randomly. This is the example of ground glass opacity, which is showing this kind of ill-defined to well-defined area of increased attenuation in the lung, which will not obscure the pulmonary vessels. You can see the pulmonary vessels inside, as contrary to the consolidation or non-contrast scan. Then here are the few examples of decreased attenuation, which includes the pneumatocysts or pneumatocyst. It develops at the sequela or complication of infection, and it will be seen as this kind of thin walled cyst or cavity, which usually it can be seen adjacent to the consolidation or collapse, and that will be a clue to identify pneumatocysts. This is the example of cyst in the case of Down syndrome. Down syndrome can have this kind of peripheral layer of subpleural cyst. Cyst can be infected, but when it is not infected, it is containing either air or cyst, and it will be very imperceptible wall of that cyst area, and that is the example of cyst. It can be of variable sizes. This is the example of moderate to severe bronchiectasis, and we are seeing this kind of irregular circular dilatation of the bronchus. That is the bronchiectasis, and this is the example of air trapping. Air trapping usually we see in the expiratory images, and we can see that it should be like we are seeing this kind of lobular areas of decreased lung attenuation, that is the more dark area, and the vessels also will be attenuated in that location. So that is the example of air trapping. Now moving on to the few case examples. That first will be starting with the airway abnormalities, which can be intraluminal, or it can be wall abnormality, or it can be extrinsic impression. So here is a case of 11-year-old child who came with recurrent lower respiratory tract infection, and in the same and each admission we were finding this kind of right lower zone near the cardiomyosine border, some sort of collapse, and this kind of tubular effusion, which was suspicious for the bronchiectasis. And just to evaluate further, CT scan was done, and these are the HRCT lung window, which showed this kind of filling defect in the right bronchus intermedius, and distally the patient was showing this kind of cylindrical areas of bronchiectasis. So this was a case of a foreign body which was stuck there, and this organic foreign body cannot be seen on X-ray, and CT can be useful for the localization of the foreign body which are not seen on X-ray. And this was a custard apple seed which was retrieved from the bronchoscope. And here's another example of 3-month-old child with stridor and recurrent wheeze. Whenever you see that patient presenting early infancy, then there might be some sort of congenital abnormality. The lung fields were not showing any obvious abnormality, but however, the trachea was not seen well on the X-ray. So CT scan was done, and the CT scan revealed something very rare anomaly, which is called as bridging bronchus. So here what we saw that at the true coronal level, we were seeing that there was rudimentary right main bronchus, and the left bronchus was continuing down, and the entire thoracic trachea was very small in caliber. And to the surprise, the right lung was supplied by the bronchus which is arising from the left side. So that is known as the bridging bronchus, which was forming a pseudocarina. So this kind of information is provided by CT scan that sometimes even your endoscope also fails to recognize, and that's the beauty of this doing CT. The same patient also had this kind of vascular anomaly in which there was left pulmonary artery sling which was compressing the right main bronchus, as we can see here that the right main bronchus was compressed by here, and it was coursing behind the left main bronchus. So that was the anomalous course that was forming a sling, and it was compressing the right bridging bronchus. These have few other sagittal reconstruction showing the airway. The thoracic trachea is very small in caliber, and you can see that these are the coronal lung window images, which is showing that the right lung is small in size as compared to the left lung. So the right lung was hypoplastic also. Then moving on to the hypoluxant or cystic lucency in the lung. So this is the example in which there was some mild mediastinal shift. However, the diaphragm was intact, and we were seeing this kind of cystic lucency in the left mid zone and the lower zone. The CT was done just before surgery, and it revealed that in the left lower lobe there was one large cyst with this kind of air fluid level. However, the adjacent lung also was not normal. It was decreased in attenuation. It was looking more dark, and it has this kind of multiple cystic lucency. These are some mini reconstructed images which is showing that multiple this kind of microcysts which are highlighted more better in the mini reconstruction, and that had fluid level in that large cyst. So the lung architecture was not normal in that lobe. So based on that, we gave a possibility of CPAM. The patient was underwent surgery, and these are the surgical images which confirm it was mixed variety of CPAM, that is the congenital pulmonary alveolar malformation. Then sometimes in a case of recurrent or non-resolving pneumothorax, CT is very useful. For example, in this case, after doing CT, we could identify that the patient was a case of necrotizing pneumonia, and you can see that the lung damage in bilateral lower lobes, and the necrosed parenchyma or cavitary parenchyma was freely communicating with the pleural cavity, so that was forming a parenchyma pleural fistula, and that was the cause for non-resolving pneumothorax in a case of MRSA positive uncontrolled infection. The same patient also had this kind of multiple loculations and septations. And in this case, we can see that if you put the tube in the posterior part, the anterior part of the loculated pneumothorax cannot be resolved. So CT is very useful in identifying those kind of practical scenario. Then moving on to the infection cause. So CT is useful for some necrotizing pneumonia or non-resolving infection, and sometimes in the diagnosis of certain viral or fungal infection. So here is the example of bacterial infection. This was a case of mycoplasma infection. Mycoplasma infection sometimes are known to cause pulmonary thromboembolism, and this was the case of mycoplasma infection with this kind of, we can see that filling defect in the left lower lobe pulmonary artery, and that was the thrombus in the left lower lobe. That was the mycoplasma infection with arterial thrombosis. Here is the example of post-bone marrow transplant patient coming with febrile neutropenia. And if you do CT, then you will see this kind of halo sign. That is the ground glass halo surrounding the nodule. So that is one of the most common pathognomonic sign of the fungal infection. It is not specific, but in this scenario, we can confidently say that the chances of fungal infection like aspergillosis are high. And if this is the same patient after 2 weeks after our treatment, antifungal treatment, we can see that the fungal hyphae has formed this kind of mycetoma with this kind of air crescent surrounding it. So that is the example of fungal wall. So this was the case of invasive aspergillosis, which was causing this kind of halo surrounding the lung nodule. Here is the example of COVID infection. Sometimes it can mimic fungal infection, and we will see this kind of irregular, nodular to fluffy ground glass opacity, which can be asymmetrical and bilobar. And sometimes the COVID infection can be very severe, and patient can undergo ARDS, and we are seeing this kind of ground glass opacity in bilateral lungs, which are more common in the more pronounced in the mid and lower zones. And we did CT scan just to look at the parenchymal damage, as the patient was not showing response to treatment. And what we could found that the patient had developed this kind of multiple fibroid atelectasis in bilateral upper lobes, and the patient also had this kind of ground glass opacity in the bilateral lower lobes, shown by the yellow arrow. Moving on to sometimes patient can go into this kind of post-COVID air trapping, as evident by this kind of lobular areas of low attenuation. And that is this patient may require some sort of long-term treatment, and they can develop this kind of bronchitis air trapping. Moving on to the TB spectrum. So CT is also useful for the assessment of the pleural empyema, and pleural empyema we identify on CT by this kind of thick peripheral enhancing parietal pleura that is called a split pleural sign, and tuberculous node will be showing some sort of necrotic and conglomerated node, as we can see, this kind of centrally non-enhancing necrotic areas. So these are the hallmark feature of the TB, which is showing this kind of necrotic nodes in the paratracheal and the subcarinal locations. TB also can have chest wall lesions, as we are seeing that there are some necrotic looking pus containing lesion in the chest wall and with the underlying destruction of rib. So just to tell you that not all rib lesions are malignant. Sometimes TB also can present with this kind of lytic lesion with adjacent collection or abscess. TB also can have this kind of tree in bud pattern, as we all know, and they can have this kind of consolidation, and Hrct lung finding will be useful in identifying those kind of findings. And moving on to some diffuse lung disease or systemic conditions, in which this is an example of a 12-year-old child who were having this kind of recurrent lower respiratory tract infection and failure to thrive. And what we are seeing that this patient had this kind of upper lobe predominant severe moderate bronchiectasis, cystic to varicoid, and the patient also had this kind of peribronchial wall thickening, areas of mucus plugging and collapse. The same patient also had in the upper abdomen this kind of atrophic pancreas and diffuse hyperdensity of the liver. So when you see this kind of finding, that is indicative of cystic fibrosis, and CT can be useful for making of this kind of exam diagnosis. So this is the fatty atrophy of the pancreas, those who want to see the pancreas. Sometimes CT can be useful for the follow-up of the interstitial lung disease to assess the treatment response. And here we are seeing that this was a case of juvenile dermatomyositis, and we were following up. As on follow-up, we were seeing that despite of treatment, the patient was having this kind of worsening of the interstitial lung disease in the form of this kind of increased interlobular septal thickening, as well as some sort of fibrotic changes. So the lesson to remember from this thing, that if you are finding the same anatomical localization on the X-ray or CT, then you have to suspect that either there is some foreign body or some congenital abnormality, or there can be a vascular cause compressing the airway. If you are saying bronchial wall thickening, then you can think of cystic fibrosis or asthma or ciliary dyskinesia kind of causes. If esophagus is if dilated, that cannot be explained, then you have to think of the patient might be having achalasia cardia, or patient might be having fistula or stricture. If you're finding pulmonary opacities in different location in multiple admissions, which is bilateral, then you have to rule out is there any immunodeficiency disorder or systemic cause. Now, moving on to the mediastinal case, we have already seen the mediastinal boundaries. So here is the infant who came with decreased movement of the lower limb. And what we are seeing that homogeneous opacification of the left mid and lower zone, which is having broad base towards the mediastinum. The beauty of the thing is that the opacity was causing this kind of binding of the intercostal space, as well as thinning and erosive changes of the posterior aspect of the lower thoracic rib. So that was the clue that this lesion appears to be mediastinum. CT was done subsequently, and which was this kind of lobulated heterogeneously enhancing soft tissue lesion, which was also extending into the spinal canal. And just to evaluate the spinal canal component, we did MRI. You can see that even the lesion contained this kind of calcific speck, which is highly indicative of neuroblastoma, because neuroblastoma can have this kind of calcification. These are the MRI images, which is showing the spinal canal component. You can see that the spinal cord was pushed towards the right side. So this was a case of neuroblastoma in which CT really helped in localization and diagnosis. Moving on to the last topic, that is the chest wall masses. So CT can be, here is the X-ray, in which we are seeing this kind of homogeneous dense opacity in the right thoracic lung field, which is more marked in the mid and lower zone, which is compressing the adjacent lung parenchyma. The thing is that you have to see the thoracic rib cage also, and here we are noticing that there is some lytic sclerotic area in the this kind of right fifth thoracic rib on the lateral aspect with this kind of minimal soft tissue bulge. In this kind of cases, you can do USC to initially evaluate whether the area looking more of a cystic or solid. This patient showed this kind of solid areas with increased vascularity. Subsequently, CT was done, and CT showed that the patient has this kind of large expansile mass lesion, and it was arising from this rib, which is showing this kind of sclerotic and lytic area, and it was compressing the adjacent lung. On biopsy, it came out to be Ewing sarcoma. So to conclude, a single phase non-contrast or contrast studies are enough for the evaluation of the most of the pediatric chest CT. And we should be using CT with the low dose technique based on the LRA principle. And we should be familiar about the patterns of the abnormal CT. So that will give you a chance to approach to how to assess the lung parenchymal disease, and it will help in narrowing down the differentials. Then, based on the location and imaging, we can give some meaningful diagnosis in a case of metastatic lesions as well as congenital anomaly. And we should be using this different reconstructed techniques like MIP or expiratory scan in a case of air trapping, and to give the maximum output from the CT scan. And by that, I'm concluding today's session. Just want to highlight that our department has taken immediately pledge that we should keep the radiation as low as possible. And I would like to thank you again.
Thank you, sir. Thank you for the wonderful and in-depth presentation. We, on behalf of IIT Raigad, we'd like to thank you for the presentation. And now we move on to the next session, that is late Dr. Shiole Memorial Oration, that will be live relay from Hall A. Thank you very much.
काय काउन्सिलिंग आहे बघू. हो, बाकी. नमस्कार. त्याची नाकानी मशीन लावली आहे काल काढून, तोंडाची मशीन त्या बाळाची जी आहे एकाची, जे Good morning, ma'am.
Good morning, sir. Welcome.
Ma'am, my lecture is there at 11:55 a.m.
Yes, sir.
Huh?
Yes, yes, sir.
So after this lecture, I think it is there.
Yes,
So
sir.
I will
Yes, sir.
share screen after that only. Huh?
Yes, sir. Yes.
Okay, ma'am. Bye.
Hello. Good morning, sir. I'm calling from online now. Okay, so we will start then. Yes.
Hello.
Hello. Good morning, friends. Once again. Now this session will start with our first topic, that is newborn screening. Newborn screening has got lots of importance since last 3 decades for early diagnosis of many conditions. Many endocrinological conditions, inborn error of metabolism, hemoglobinopathies, and various other conditions we can diagnose with the help of the newborn screening. To elaborate further on this topic, I would like to invite Dr. Allergic Chess, sir. So over to you, sir. At the same time, I would like to share one small video for all of you. Over to you, sir.
Very well, good morning to the entire Mahapedicon group, and it's pleasure from Metropolis to present this nice topic, newborn screening. And as you know, we all know that newborn screening nowadays in India, there is a lot of debate where we should make it mandatory, at least for the panels which IAP has suggested. So to dip into it, and from the laboratory aspects, basically how a newborn screening can be helpful, I'm going to take you through a small presentation. So I'll just load my presentation. I hope my screen is visible. Yeah. So just to introduce myself, I'm Dr. Alap Christie, and I head the clinical chemistry as well as the quality assurance for Metropolis Healthcare Limited. And I have experience in the clinical chemistry, quality assurance, lab management over a decade, and I am interested in the publications. Definitely have, interested in academics, as well as we have mentored several projects. And metabolic disorders is something which is area of my interest, and I also work closely with the laboratory automation to bring a more robust techniques. And yes, so this was about me. So in today's presentation, we will be talking about these objectives. These are the abbreviations. Now, newborn screening, why basically is needed? So we received a plasma sample of 2-year-old male child for confirmation on LC-MS plasma amino acid analysis. Now this is basically not newborn screening, but this is a later child when 2-year-old male child's sample was received, and we were asked to do a plasma amino acid analysis. The phenylalanine was 2279 micromoles per liter, and tyrosine was 76. The reference ranges were phenylalanine up to 104. So if you see, the phenylalanine was quite high. Tyrosine was normal, and other amino acids also were not significant. We asked for a repeat sample, we retested, again the phenylalanine was high. Then we consulted the pediatrician, and we asked for the clinical presentation. So the physicians basically give us the history that the child was having frequent seizures, stunted growth, skin rashes, eczema, and mental retardation in terms of delayed milestones. So basically, this child was diagnosed as phenylketonuria. Now, when we dip into it and we ask the pediatrician that did we do it at the time of the birth? Did we go for a newborn screening? So pediatrician says yes, I had, but then the parents said that there is no need. So it's okay. We don't want to prick our child. So it was denied at birth. But now, so was it too late? So this is a scenario right now in Indian subcontinent where we still do not have that much of awareness about the importance of newborn screening. So newborn screening is basically, as we all know, it's a practice in which every newborn is tested soon after the birth for all the genetic and metabolic disorders. The purpose of the newborn screening is early diagnosis before even the onset of symptoms, so that we can prevent the disease progression. And the goal of newborn screening is early detection of children at increased risk of selected metabolic and genetic diseases. So every child deserves a healthy start. So back in 1961, Robert Guthrie, when his own son was having a mental retardation, and he could not diagnose the condition behind that. But when his niece, she also had the same kind of mental retardation. At that time, there was a ferric chloride test which diagnosed it as a phenylketonuria, but that test was very crude. So then he found out a microbiological technique where a filter paper was used, and then that filter paper was basically in that the bacterial growth was basically in the presence of this particular the phenyl lactate phenyl pyruvate. The growth of the bacteria was basically observed, and that indicated whether the presence or absence of a phenylketonuria. That basically hit as a screening test for phenylketonuria. And when that happened, that paper is still used right now, even in our laboratory, because that's a very good concept. It's a small drop of blood from the heel of the child, and that dry blood spot basically, which we use, and then we dilute it, and then we run a lot of tests nowadays. So this is how it started, and now it has reached to a level where, up to a great sensitivity with the equipments like mass spectrometry, we are able to detect this amino acids, fatty acids, and whatnot. So just to make you aware of the global trend, in United States, basically it requires the newborn screening for at least 29 core health conditions, and each test has different criteria. But if we see the entire United States statistics, 99.9% of infants, they are basically screened at birth. And in India, we may be hardly having 5 to 6%. So the latest CDC data shows that 34 out of every 10,000 newborns screened are eventually diagnosed with some of the other metabolic conditions. In UK, we have major 10 disorders like phenylketonuria, congenital hypothyroidism, cystic fibrosis, sickle cell disease, and then these MCADs and GA1, MSUDs, 10 different types of disorders they basically screen as a mandate. In Japan also, basically minimum 5 PKU, MSUD, histidinemias, HCU, and galactosemia. It has started in 1977. So if we see the India, then India is a country with very high birth rate. 25 million births are annually there. In one of the earliest studies in India, biochemical screening of 4,400 cases of mental retardation revealed that out of 4,400, 256 cases, that is 575%, were because of inherited metabolic disorders. Now, these 256 disorders could easily have been prevented if they could have diagnosed at the earlier stage. ICMR basically says that 4.9% of genetic causes of mental retardation are due to the metabolic disorders. So yes, if we see, the mental retardation and the developmental delays, and also at the later stage, the life expectancy, everything you can definitely improve if you diagnose at early stage, if you can restrict that particular diet, if you can treat the child. So from 2014 to 2020, we did close to 1.5 lakhs tests at Metropolis. And, the majority we got for the G6PD levels, and then the neonatal hypothyroidism as well, for galactose, for phenylalanine, biotinidase, for all basically we got. So out of this 1,31,000 cases, 1.3% were found positive. That is, they showed the abnormal results. And if we talk about the positivity, G6PD deficiency was the major one, as you know, 39% of cases, followed by the neonatal hypothyroidism, and then followed by the R17-hydroxyprogesterone, that's a congenital adrenal hyperplasia. Now, as we all know, what is inborn error of metabolism is whenever any substrate has to be converted into product by the enzyme, and if that enzyme is defective, then if it is damaged, then there is no product, and because of that, the substrate and the byproducts basically accumulate in the body, and then they start creating the toxic effects. So if we talk about the galactose metabolism, here if UDP galactose 1-phosphorase uridyl transferase enzyme, which if it is defective or absent, then basically the galactose 1-phosphate will accumulate. So this is the galactosemia. If we classify the inborn errors of metabolism, then there are different types. It can be due to errors in carbohydrate metabolism, or urea cycle, or the organic acid ureas, or the fatty acid oxidation, or the mitochondrial function, paroxysmal function, lysosomal storage disease, your nucleic acid metabolism, amino acids, carbohydrates, anything. The common ones are majorly, with the urea cycle, some organic acid ureas, fatty acid oxidation defects, and the amino acids. These are the common ones. LHDs and all, yes, not that common right now, but definitely are the areas of interest now. So now, what do we target in a newborn screening is basically the amino acid disorders, organic acid disorders, the fatty acid oxidation disorders. In amino acid, we target urea cycle disorders, the cases of hyperammonemia, then the homocystinuria, the non-ketotic hyperglycinemias, your MSUDs, your PKUs, And when we talk about the organic acidurias, basically this test targets on the glutaric acidemia, GA1, isovaleric acidemia, beta ketothiolase deficiencies, methylmalonic acidemia, recent case we saw, interesting one, propionic acidemia. For fatty acid also, the medium chain, short chain, long chain, very long chain, CoA dehydrogenase deficiencies, and there was a carnitine transport defect. So these are the tests, these are the disorders which basically, we diagnose with the newborn screening, because in the screening level, we have a limitation. We are doing with the dry blood spot, but still we are able to diagnose almost above 45 conditions. And then some of the tests we do by another technique called as ELISA, in which, biotinidase deficiency or G6PD or congenital adrenal hyperplasias, hypothyroidism, cystic fibrosis, all those disorders can also be identified. So the standard approach for the newborn screening is, a Hill-Pricks blood sample collected, a preliminary report is generated, and then the retest is conducted. So if at all the preliminary report is positive, then, it's a mandate to conduct the retest, in another sample, and matching results with the first test called for the confirmation. Now, here basically, it's a tricky situation. Now, at times when the child, when the infant is born, at that time, if the infant is premature, if at all, they are put on the total parental nutrition, or if at all, the formula which has been given, that might falsely elevate the amino acids and falsely elevate some of the fatty acids, and, might give a false picture at times. So it's very important that, before putting the child to the TPN, the sample is collected. But yes, another thing is here, the sample has to be collected within 48 hours to 7 days. So that's something which is very important. And once you confirm that, okay, now the clinical diagnosis is definitely projecting towards something, then you might want to go for a confirmatory test as well. So that will be in the urine or plasma, and it will not be in the dry blood spot. And then, you can do a enzyme analysis as well. You can go for the genetic testing. Some of the molecular diagnosis, diagnosis modalities are available for the enzyme analysis. And then you initiate the treatment. So the, there are important steps when it comes to the dry blood spot collection. If something is, as I told, 2nd to 7th day of life is something where it's a representative pictures. At times we get a request that the child is 12 days old, please collect the sample. And then when we talk to the pediatricians, and then they know basically at that time, is it the correct time? So I would say that the cutoffs which are derived for any amino acids or fatty acids or, acyl carnitines, that is between 2 to 7th day of life. And hence, if the levels are increased or decreased at a later stage, it may not be representative, and you might not get an accurate diagnosis. So I suggest that the ideal time is 2 to 7th day of life. And, even the staff who are collecting the sample, they should be trained in terms of, not to touch the paper with bare hands, because even the sweat, on the saliva of anybody else can basically elevate the amino acids and other substances, which might give you false positive result. The area has to be properly cleaned, and then, first, basically the first drop you have to let go of, and then another blood drop that basically you have to put on the filter paper, and it should be into that particular circle, so that and also you should never dry that paper with the hair dryer or anything. You just keep it in the air and let it dry, and then put it in the envelope and send it to us. Advantages of this dry blood spot is definitely, it's a simple collection, and most of the analytes are very stable. Transportation is simple, storage is easy, compact, it's a whole blood matrix. Safety handling exposure is not there. You just put it in the envelope, send it. And it's a centralized laboratory with us who basically, process that sample. And handling and storage. So basically there are variables which affect the measurements of DBS, like, handling and storage of paper, humidity condition of paper, volume of blood collected, hematocrit level of blood, absorption time for the blood. So now the equipment which we use is called as tandem mass spectrometry. Tandem mass spectrometry because it has 2 different mass spectrometers. So the system which is used is Vortex, Zivo 2D, and ABSciX. So I'll just, go through the technology a little bit. I'll just show a small video. So this is a mass spectrometer. And, I just want to talk about the sensitivity of this technique. So once the sample is prepared through a nebulizer, the sample is basically thrown into this mass spectrometer. Now what happens is, once this sample comes, then a sample basically comes along with something called as mobile phase. Now they enter into the sampling capillary first. Now, because it's nebulized, it's in the form of the ions. Now here what happens, there is something called as a skimmer cone. Skimmer cone will basically, filter out the bigger molecules, the molecules which are not of interest. And only the molecules which are of interest, they basically will go into the octapole. And this octapole will basically, create a movement for this particular ions. Now, these ions, when they reach something called as a quadruple mass filter, they're based on the settings that, I want to get a particular mass of amino acids. Then, I will allow only those amino acids to pass or those fatty acids to pass. So those molecules only will pass to something called as the collision cell. In the collision cell, basically, there are gases which basically gives charge to these ions. And then, there is something called as mass to charge ratio, which is unique for particular, molecule. Now, once these charged ions basically go to the next phase, then what happens is basically there is called as the exit lens, and from that there is a beam shaper. In beam shaper, there is another mass spectrometer, which will basically further, filter out the molecules which are not of interest, and then only will allow, the molecules which are of interest to pass through. Now, once these molecules basically come out, into something called as detector, there is something called as conversion diode. So now what will happen is the amount of electrons basically which are produced, the charge basically which is released, that charge is then detected through secondary diode, and it goes into the something called as the electron multiplier. So here, the technique is so robust that basically a lot of filtration happens, and you get the molecules of choice, very, very sensitively. That molecules are, have a particular absorbance, have a particular mass to charge, and that's why the detection becomes very, very sensitive. And that's why this is the very, latest technology, and many labs are using it. But how to use it correctly and all those things, that is something which is an art. So definitely, you need very trained manpower, and luckily we have a good experience in LCMS. So we do it in a proper way, so that we get a good sensitivity. So if we talk about the technology itself, then basically it's a liquid chromatography tandem mass spectrometry. And after the initial screening step, it can also be used in screening positive samples as a second tier test. So basically, you can do the newborn screening as well, along with that, as a second tier confirmatory test as well in the plasma urine. And it can measure different amino acids, acyl carnitines. So now I will not go through these in detail, because these guys know far better than us, definitely, because the symptoms, treatment, all these things. But just to enlist the disorders like urea cycle, homocystinuria, and the major symptoms of that, and how to basically treat, what are differential diagnosis. For example, there is a case of non-cirrhotic hypoglycemia, then you have a differential diagnosis of urea cycle defect, or propionic or isovaleric acidemias, or multiple carboxylase deficiencies. Similarly, for the MSUD, you have different kind of differential diagnosis. So yes, similarly for the glutaric acidemia type 1, the differential diagnosis can be Ray's syndrome or the encephalitis, because of the symptoms there. There's a muscle weakness, there's a hypotonia. So yeah, these are the different types of disorders. Now the general approach. General approach is basically, if a child is born at that time, at times the first thing generally which we do is we go for a blood gas analysis. If there is a child which you are suspecting that might be having some abnormalities. Now, if there is a metabolic acidosis with raised anion gap, then you will measure the lactate levels. If the lactates are elevated, then you can go towards mitochondrial disorders or the disorders of pyruvate metabolism. But if lactate is normal and if your urine ketones are there, then you basically, urine ketones, if they are present, then either it can be organic acidemias or it can be MSUDs. But if it is absent, then, the suspicion goes toward the fatty acid oxidation disorders. And, similarly, your blood gas definitely shows the alkalosis, then it can be urea cycle disorders. Now, this is the, this is something when you are actually suspecting something. So when you get a clinical picture that, okay, the child, you're suspecting something inborn of metabolism, then this is the approach. But if at all the child does not show any symptoms, then the best way to detect is your newborn screening. You just go for a Hill prick, get the test done, and you will get the entire diagnosis. Some people use the hypoglycemia approach, when there is a hypoglycemia, and they basically go for the non-glucose reducing sugars. If they are present in the urine, then they consider the galactosemia or tyrosinemia. If it is negative, then you will go for the urine ketones, plasma, amino acids. Now, at this stage, this is generally a stage which is little later, after 15 days, 20 days, or maybe, after a month, when the child, comes to the clinic with hypoglycemia. So at that time, you don't screen, you basically directly go for the, plasma testing and urinary testing. And then your hepatomegaly will tell you whether, if hepatomegaly is present, then probably it's basically your glycogen storage defects, or it can be beta-thiolase deficiency. And if at all hepatomegaly is absent, then you can consider your ketotic hypoglycemias and your endocrinopathies. Similarly, some people use the metabolic acidosis approach, and then, they diagnose. But these are the scenarios where, you do it in a later life, when you are not able to detect something by newborn screening. So I would suggest that, rather than putting the child to this situation, it's always better that we do a quick newborn screening at the 48 hours of life. So as Metropolis, we have a brand called as Neo Expert, and Neo Expert because we kind of have a lot of profiles for the newborn screening, something which is recommended by IAP, which is minimum. So if at all something has to be offered, then if the parents are not affording, something which can be easily offered is at least 3 tests: TSH, G6PD, and 17-OHP. Because G6PD also, in some of the clusters of the country, they are high. So at least these 3 tests can be given. The fluorescence enzyme immunoassay is a method which is used to detect that. Then there is a panel called as Neo Expert 5, which will give 2 more analytes, phenylalanine and cystic fibrosis. Then another is Neo Expert 8, which will go 3 more analytes like galactosemia, biotinidase, and MSUDs. But the one which is of interest is, your Neo Expert by TMS, and then the expanded screening panel. So expanded screening panel is something which covers everything, which covers your, TSH, G6PD, 17-OHPs, and all those things. Apart from that, it will cover the amino acids and also the acyl carnitines. So around 48 parameters it will cover. And if someone is suspecting a specific kind of a marker, to do that, we have G6PD test as well, TSH also separately, leucine also separately, cystic fibrosis also separately. So we have separate tests also available. But yes, I would suggest that if at all we are going for it, then why not to go for expanded panel? It covers everything and it gives a better picture.
Sorry to interrupt you, sir. Only 2 minutes are remaining.
Okay, this is my last slide. No issues. Yeah, reporting of results. So this is the screening test, and these are the second tier confirmatory test. Definitely, so if at all we are suspecting like amino acid disorders, then the second tier test are DBS and TMS, plasma urine amino acid genetic test, etc. And so yes, definitely a confirmatory testing is something needed because it's a screening test. But yes, definitely it will help you to detect it in an earlier phase. So yeah, as early as 2 to 7 days of life, you should get it done. Sick and premature babies should have the metabolic screening by 7 days of life. Positive screening test should always be followed by a confirmatory test. So yeah, that's it from my end, and it's a pleasure talking to this entire group. And thank you so much.
Thank you, Dr. Alakrisi, sir, for explaining technical details of newborn screening and recent advances in diagnostic modality. Thanks a lot once again. Now we will move on to the next topic for today, that is nutritional supplements for preterm. Salvaging preterm and assuring their normal physical and cognitive development has been a great challenge for pediatricians. It also makes us salute nature. Despite of all our advances, we can never recreate the intrauterine milling. To tell us how we can go as near to nature as possible, we have respected Dr. Sandeep Patil, sir. He is a renowned pediatrician. Over to you, sir.
Thank you, ma'am. I'm audible and visible?
Yes, sir. Yes.
Should I share my screen?
Yes, sir. Go ahead.
Please make me host now. Then only I will be able to do it. Is it now visible?
Yes, sir.
My slides are also visible, na?
Slides we cannot see yet, sir. You have shared the screen, but slides have not yet started to show.
Slides are open already.
Hello. Hello.
Is it visible now?
Sir, we can see your screen, but we are not able to see the slides. It is just showing welcome to WebEx team. Hello. Hi, Doctor. Just a minute.
No, I have shared the screen, but it's not.
Hello, Dr. Sandeep.
Yeah, ma'am, tell me.
Hello.
Ah, ma'am, tell me.
Am I audible, doctor?
Yeah, you are audible, ma'am, but I am not.
I'm not able to hear you, doctor.
Huh? I am audible or no?
Hello. Hello.
Ah, ma'am, I am audible or no?
Sir, you are.
Am I audible, doctor?
Yes, yes, you are also audible, and Dr. Sandeep Patil, sir, is also audible to all of us.
See, I am sharing the screen, but I am not able to show my image. I am not able to share. See, please make me host. Then only I will be able to share. Now, is it shared?
Yes, doctor, we can see your screen. Please carry on.
This and my slides are shared now.
Yes, sir. Yes, sir.
Yeah. Okay.
Thank you.
Good morning to one and all. Basically, we are going to discuss today now about nutritional supplements in preterm babies. So this topic will be discussed under the following heads. First, we are going to discuss about the definition of what is neonatal preterm supplementation. Then we are going to see about what are the supplements we are going to consider in that. There are many supplements, the basic supplements, as well as there are few supplements which are very useful, and what is the role of other supplements which are not we are using in common, but we are going to discuss about them also. Then we'll see how we are going to monitor about the supplements, what we are giving and what effects we are getting. Then we are going to see about the complications of not supplementing the preterm nutrition. So we are going to discuss one by one about these different supplements. Now we'll move ahead with we should know about that the human preterm milk is higher in protein, sodium and calories, and there will be a difference between preterm human milk and term human milk till 3 weeks of gestation. Means 3rd week of postmenstrual age, there will be this difference. And maximum permissible volume also have low minerals and vitamin content. So preterm human milk is having lowest content of minerals and vitamins, even if we are giving highest permissible volume. That means if we are giving 180 to 220 ml per kilo per day of volume of preterm human milk, that is going to have some deficiencies of minerals and vitamins. And that makes us to make supplement the nutrition of these preterm human milk for these preterm babies. Okay, so this is the basis of supplementing preterm milk, and we should know there are multiple things, definitions come for what is supplementation. Then we will see about complementation and that. So what is neonatal supplementation of a preterm human milk? Supplementation is adding something in human milk so that it gives some additive nutritive value in that, where milk is supplemented with other like minerals or vitamins or iron or calcium. These things you are going to add. Complementation is nothing but in addition to milk, you are going to give some semi-solid or solid food to the child, and that is a complementary feeding of a neonate or a pediatric patient after 6 months of age. So till 6 months, we are doing only supplementation of feed, and this supplementation of different minerals as well as vitamins, we are going to discuss it here. Now, the goal of each nutrition is we have to achieve in utero growth standard of these preterm babies. So what is in utero growth standard? Here, the weight wise, if we are going to see, 15 grams per kg per day of weight gain baby should achieve, which baby achieves in utero. And the accretion of the all minerals as well as vitamins, which is happening in utero from preterm to term gestation, that we are going to match in preterm nutrition. That is the supplementation target or goal of this nutrition. And if these babies are born preterm, we should know that there will be a fluid loss as well as there is more catabolism, and that more fluid loss and catabolism makes us more and more make prone for adding supplementation in preterm feed. So the main difference in fetal nutrition and neonatal nutrition, if this baby is born preterm, is that high protein intake or high protein supply will be there for this fetal during fetal nutrition, and there will be a low protein intake or low protein supply during neonatal intake. There is a lot of difference in that, but here I am going to discuss not about these macromolecules or macro supplements such as carbohydrates and protein and fat, but we are going to discuss about the minerals and vitamins which we are going to supplement in all preterm babies. So to make a base, you should know that why we are supplementing, that as we have discussed in the previous slides, that basically we are going to supplement to achieve the neonatal accretion in the, if this baby would have been in utero, or and to achieve the baby's actual weight gain or actual have a physical growth in the form of length and head circumference gain of the babies. So I have put here a slide to show that this is the RDA, that is recommended daily allowance, or it is also called as RNI, that is recommended nutritional intake of the child. So this is the recommended amount of mineral the baby should get of calcium, that is 210 milligram per kg per day. Means we should give to preterm babies, if the baby is a 1 kilo and if the baby is on some of the milk, then baby should get 200 milligram of calcium in a day. So to sensitize you, I had put in front of you how much is the content of calcium and phosphorus in a preterm expressed breast milk. So you can see that in 100 ml of preterm human milk contains 23 milligram of calcium only. So if you are giving highest volume of food or milk to that child also, we are going to give, if you are giving 200 ml per kilo, 23 2 is 46 milligram of calcium only you are going to give to a preterm baby. And you can see that the baby's recommended daily allowance is 210 milligrams. So this much of lack is there. That's why we have to supplement even if baby is on exclusive preterm maternal milk. Now we'll go one by one with these minerals and vitamins. So first is calcium and phosphate. So I have made it very simple. Whom to give, means which babies we are going to give calcium. We should not give to all babies who are born more than 34 weeks of gestation. We should give to the babies if these babies are less than 34 weeks of gestation by birth, or birth weight of the child is less than 2.5 kilos. When we are going to add, when the baby reaches the fluid volume of 100 ml per kilo per day of feed, then how much we are going to add, as we have discussed, as the recommended daily allowance is 200 milligram per kilo per day. So calcium we are going to give is 150 milligram per kilo per day. And phosphate is always in the ratio of 2:1. So half of the phosphate you have to give to the child. Clear? Then how long we are going to continue? Till the baby achieves the postmenstrual age of 40 weeks, means complete full-term baby. Till that point, you have to consider for giving calcium and phosphate to child. And what should be the ratio of calcium phosphate? As I already discussed, it should be 2:1. Preparations in preterm baby is different from preparations in term babies. That you should give more importance to that. This is the topic which I am not going to discuss about term baby calcium supplementation. I am going to discuss about preterm baby supplementation. So in preterm baby, you should keep in mind that any calcium preparation which you are giving should contain phosphate. It should not be without phosphate. If you are not giving phosphate to the child, that is going to cause hypercalcemia, and then you are going to make more and more baby more prone for other diseases like osteopenia of prematurity. Then there will be more hypercalcemia and hypercalcemia related problems. I am putting these different calcium preparations which are commonly used in practice. My aim here is to sensitize you that the different preparation contains different amount of calcium in that. So first preparation, you can see 82 milligram of calcium is there in 5 ml. Second preparation, it is 150 milligram of calcium in 5 ml, and 5 ml of last preparation contains 125 milligram. So whenever you are prescribing, try to calculate as 150 milligram per kilo of calcium. So if the middle preparation, if you are using, so you can consider that you are going to give 5 ml per kilo. If the baby is 2 kilos, you are going to give 10 ml of calcium in a day. So whenever you are prescribing, advise as 3.5 ml every 8th hourly or 5 ml twice in a day. So multiple times you can find that parents may ask you the question, sir, whether we should give 10 ml of calcium to that child, because when I was pregnant, my obstetrician has advised me to take 5 ml twice in a day. Requirement of preterm baby is very high. So please try to calculate according to the preparation you are using and then use appropriately that calcium preparation. Okay? Now we move ahead with vitamin D, which is very commonly used preparation. So in whom we are going to use? To all preterm babies. I am not going to discuss about here about term babies, but in all units you are going to use vitamin D, whether preterm or term. When you are going to start? When the baby has reached feed volume of 100 ml per kilo. And how much you are going to give? Around 400 international unit to 1000 international units. You should not give less than 400 international units per day. That you have to keep in mind. Clear? Then how long you are going to give? You are going to give till the baby becomes 6 months to 12 months of life. In our practice, our unit protocol is to give till 1 year of age. So we give vitamin D supplementation to all preterm and term babies till 1 year of age. And without adequate supplementation of calcium and phosphate, you should not give vitamin D. Why? Because if you are giving vitamin D alone and not supplying calcium and phosphate to the child, what vitamin D does? It increases the absorption of calcium from intestine, and baby needs and it again increases the blood calcium level by resorption from our skeleton. So if you are not giving calcium in adequate oral intake, that is going to cause more and more calcium resorption from your skeleton, and then more complications are going to happen. So whenever you are supplementing with vitamin D, please try to consider supplementing with calcium and phosphate also in a preterm baby. These are the available preparations available commonly, which are available, that I have put in front. In last 4-5 years, if you are see thousands of preparations of vitamin D had come, but any brand you use, you keep in mind how much is the international unit in 1 ml of this vitamin D. At least lowest volume you have to give is 400 international unit, and maximum you can give is 1000 international unit. So be familiar or be seasonal with your what preparation you are using. As I told about calcium, I am telling about vitamin D also. Try to use a preparation which is going to give at least 400 international unit of vitamin D till 1 year of age. Correct? We will move again for another molecule, that is iron, which is third common molecule we are using in preterm nutritional supplementation. So iron is used for prevention of anemia of prematurity, and when we are going to start that, usually we are going to start by the age of 2 weeks to 6 weeks of gestation. That is, at 2 weeks earliest you can consider for starting iron in a baby, and highest age is 6 weeks of postmenstrual age of the child. And you should keep in mind, baby should not have any active infection, because free radical formation will be high whenever you are giving iron to a preterm baby. So baby should be between 2 weeks to 6 weeks, and there should not be any infection. How much you are going to give? The more preterm, more volume is needed, more milligrams or more content of vitamin or more content of iron is needed. That is 4 milligram per kilo. And the baby, as more towards maturity, you can give about 2 milligram per kilo per day of iron. How long we are going to give? We are supplement till 1 year of age. Clear? There are different preparations available, but almost all preparation gives a calculation of 1 drop is equal to 1 milligram. So these preparations almost all have a 1 drop is equal to 1 milligram. So if a 2 kg baby is there, you are going to give, if you are giving with 3 milligram per kilo, 6 milligram of iron you are going to do. So you have to give 6 drops in a day. So keep in mind, whatever preparation you are using, you should consider for using in an appropriate dose format. Third, another fourth molecule is vitamin A. So theoretically, there are beneficial effects of vitamin A on CLD and mortality. Almost all studies have used intramuscular doses of vitamin A on alternate days till day 28 of life of the child. It has given some result. Oral studies, oral preparation studies have shown some promising results, but there are no conclusive evidence about use of vitamin A. So vitamin A is having a doubtful role for prevention of CLD as well as mortality. So evidence doesn't support routine use of vitamin A as a single molecule for preterm babies nutritional supplementation. Another role is of vitamin E. Vitamin E is having very good effect of reducing IVH as well as increasing hemoglobin by some grams of hemoglobin. But on the contrary, it has increased the incidence of sepsis. That's why in Cochrane meta-analysis of 26 studies, RCTs, it has clearly told that vitamin E supplementation as a routine is not advised. Clear? So vitamin A and vitamin E we are not going to routinely use. Another component, you can see that some different preparations are coming for DHA or long-chain polyunsaturated fatty acids. So theoretically, they have benefited as increasing visual acuity, good neurodevelopment of babies in whom it has been supplemented during antenatal period as well as postnatally, and good physical growth. But meta-analysis doesn't support routine use of DHA or LC-PFAS. So there is no routine recommendation of LC-PFAS. Now comes our fortifiers. So there are different fortifiers which are available in the market. We should know the proper use of these fortifiers. So as it means it is a human milk fortifier, it should be added in the human milk only. It should not be added in a formula milk at all. It should be added in a human milk, and whom we are going to use to the babies whose weight is less than 2 kilo or the baby is less than 32 weeks of gestation. And how long we are going to use? Maximum till the baby attains the weight of 2 kilos. After 2 kilos, there is no role of human milk fortifier. There are certain practical points I try to put in front of you. Now, previously 2 gram sachet used to come. Now 1 gram sachet is available in the market. So the 1 gram sachet has to be added with 25 cc of milk. And do not miss, as I told you, you start fortification when the baby reaches 150 ml per kilo of fluid volume, and still the baby is not getting adequate weight gain, that is 15 grams per kilo per day of weight gain is not there, then only you are going to fortify baby's preterm human milk. Another important point, whenever you are giving HMF sachet to baby's preterm milk, there is no need of giving calcium and phosphate as well as vitamin D to the child. Previous HMF never used to contain, has a content, was not there, iron. So we used to give iron to the baby, but now preparations which are available of HMF contains iron. So you need not have to give calcium, phosphate, vitamin D and iron to the babies who are on HMF fortification. If you are giving adequate volume, means if in every 25 cc, if you are adding each single sachet, it is going to give adequate amount of calcium, phosphate, vitamin D and iron to the child. And whenever you stop fortifier after 2 kgs, you have to keep in mind, you have to add these all, calcium, phosphate, vitamin D and iron, you have to add to the babies for supplementation. There is, because only preterm human milk is not going to supply all that. There is a limited efficacy and safety data for recommending routine use of HMF sachet. Our unit protocol is to use to the babies in whom weight gain is adequate, in spite of we have reached more than 150 ml per kilo per day of fluid volume to that child. This is the content which I put in front of you to show that now it is containing iron. 1 gram of HMF gives 0.3 milligram of iron. So if you are using in adequate quantity, you need not have to supplement with iron also. Then comes the role probiotics. Probiotics have a good role for decreasing mortality as well as decreasing late onset sepsis and necrotizing enterocolitis in neonates. So multi-component probiotics are in use for all babies from day 1 to day 28 of life, for prevention of NEC, for prevention of late onset sepsis till day 28 of life in preterm babies. So what is our unit protocol? We use the preparation of probiotic which contains lactobacillus and bifidobacterium. There are multiple strains available, multiple preparations are available, and multiple quantity of probiotic is added, but the best evidence suggests that the good results are with lactobacillus and bifidobacterium. So we use this. Whatever your, according to your unit policy, you may change. Unit policy may change depending on what kind of NEC percentage is there in our unit, and try to find out that which available preparations are there which are according to your patients and try to use that. Then comes zinc. Zinc is having also good role for cell differentiation. It increases the immunity. You can see that zinc is very commonly used for respiratory infection in neonates, also in preterm babies, as it is a good growth factor for cell differentiation. It is having role in preterm nutrition supplementation also, but it is not as a solo medicine. It is not used in common. So what we do is, in our unit we use multivitamins, zinc containing preparation. So the daily requirement should be around 200 to 400 microgram per day should be there. So the different preparations which I can't name on this common public platform, but the different preparations which are coming as a multivitamin, multi-mineral component, you should check that it is containing zinc. If it is containing zinc of around 200 to 400 microgram, then you can consider for using that. Zinc is having very good role. Then after giving these supplementation, you should know how to monitor that. Whether if you are giving these supplements properly, then there is some physical monitoring of these preterm units, and there are certain lab parameters which are needed. Physically, we usually monitor weight, length by and head circumference, and lab parameters wise, we check at a particular interval about acid-base status and some mineral component we check. So when we check about physical parameters, in preterm babies, we check 3 parameters, that is weight gain, how much it is happening. The baby should gain weight after day 14 to day 21 of life, that is 15 gram per kilo per day after crossing birth weight. So then we are going appropriately. The length of the child baby should gain at least 0.7 to 1 centimeter per week. Head circumference is also same, 0.7 to 1 centimeter per week. If it is not happening, then you should relook into your fluids, and then you should relook to your about supplementation and how much calorie, protein and minerals you are giving. Like that, you have to see, recalculate every day about these things, and then you can monitor the child. In lab monitoring wise, simple, you have to see every fortnightly if you are using these supplements alone. But if you are using HMF human milk fortifiers, then you should consider for weekly, because it is having high osmolarity. If you add into a preterm human milk, the osmolarity is going to be very high. So at that time, you should measure about calcium, phosphorus, alkaline phosphatase, and sodium weekly. And similarly, till we have to do baby reaches, till the baby reaches up to 40 weeks of postmenstrual age. Now we have seen about how to add, what to add, how long to give, and what are the benefits. But we should know that if we don't do that, what is going to happen? Multiple diseases are going to get origin. If you see from the beginning, if you don't add calcium, phosphate, and vitamin D, the baby is going to have osteopenia of prematurity. A lot of complications associated with that. If you don't add iron in baby's preterm nutrition, baby is going to have anemia of prematurity and complications associated with that. If we don't add zinc or multivitamins to the needed people, then we are going to have multiple infections and going to have more complications like ROP, CLD, and that. Similarly, protein status of the child is going to decline. Physical growth wise, it has been shown in multiple studies that worsening mineral status reduces height of a child who is not supplemented properly by the age of 2 years. And late hyponatremia in babies also very common. So if you are supplementing in proper fashion in an adequate dose, you are going to have a good physical as well as a good neurological outcome of a child in the form of good visual acuity, good decreased chances of ROP, decreased chances of CLD, and good neurodevelopmental outcome at 18 to 24 months of life of the child. This all I want to tell. This doesn't include all, but I try to keep it very short fashion so that practically what we are using in a day-to-day life about the major minerals and vitamins which are in use, I try to put in front of you. Thank you very much. Any questions are there, you can put in a chat box.
Thank you very much, Dr. Sandeep Patil, sir, for this very useful lecture. Now we will move on to our next lecture for today, that is Nextpox and next generation varicella vaccine. We all know that vaccines do not have 100% protection, and if that vaccine is costly, more is expected from it by the parents. Nextpox is one vaccine that promises to be a step ahead of other varicella vaccine. Dr. Piyali Bhattacharya will highlight the advantages of it. Dr. Piyali Bhattacharya is a consultant pediatrician currently practicing at Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. She has been a president of Academy of Pediatrics, Uttar Pradesh, and she has been awarded various awards, and she has many publications in national and international journals in her name. So I invite you, ma'am, and over to you.
Thank you so much, Manju. So we have this symposia in which we are discussing varicella and the next generation varicella vaccine. So when we talk about varicella, this is a report from the newspapers which I've found that chickenpox outbreaks have not been uncommon in our country. And since the introduction of varicella vaccine, maximum infection prevalence has now shifted to the preschool, from the preschool to the later years as well. So the exact incidence in India is not known, but Integrated Disease Surveillance Programs, IDSP, has reported an alarming rise in the last few years. Possibly, maybe there could have been an increase in reporting as well. When we talk of the epidemiology in India, there are more than 1 million cases per year, with a hospitalization of 3 per 1,000 cases and deaths 1 per 60,000 cases. And the disease burden we shall see again is greater than 90% cases are in children, greater than 70% hospitalizations are in children, and 50% deaths are in children. Highly contagious with a secondary attack rate of 85 to 90%, And as I have said, the peak incidence of the disease is 2 to 8 years, and in less than 6 years, it is between 52 to 70% infection. Limited data is available on the prevalence of antibodies to varicella in India, and reports from South India have revealed that close to about 30% of adolescents, even above 15 years, are susceptible to varicella infections. And about 90% of non-immune household contacts of someone infected with varicella will contract the disease. What we already know is that it is a natural infection. We know they acquire a lifetime immunity unless the caveat being that the virus reactivates years after to cause herpes zoster. Here again, I reiterate that varicella is a vaccine preventable disease. So now this is the picture that you see of varicella. There can be macules, there can be papules, there can be vesicles, there can be crusts, or there can be pleomorphism, where all stages of the rash are seen simultaneously. Complications are seen in 2 to 6% of population, and it can be serious, even life-threatening, especially so in babies, adolescents, adults, pregnant women, and people with weakened or immunocompromised system. So even healthy babies or healthy children can have serious life-threatening complications. So we have herpes zoster later on. We have you can see the pictures where the complications are there. That is bacterial infections, pneumonia, osteomyelitis, septic arthritis. You have neurological cerebellar ataxia, and the dreaded one, of course, is meningococcal encephalitis, meningoencephalitis, and the acute disseminated encephalomyelitis or ADEM with convulsions. So you have transverse myelitis, you have GB syndrome, and you have acute infantile hemiplegia. Also, you have some peri, endocarditis, hepatitis. Almost no system is left unturned. And of course, specific to India, we find a lot of pneumonia, we find a lot of meningitis. Now, this is a beautiful study where a total of 1,609 volunteers from birth to 40 years were included. And, the total IgG antibodies against varicella zoster were determined. Once they checked for these, the study found that the serosurvey says that by the age of 10 years, you can see over here, by the age of 10 years, only about half the children are acquiring antibodies. So if that be so, they are susceptible to the disease. So moreover, a tropical climate like ours would mean higher mean age of infection and susceptibility, more severe disease, and more morbidity and mortality. Even with IDServe, what do we find? Our IDServe says between 2010 to 2013, we've been reporting at least 10,000 plus cases, of which 15.4% were between 1 year to 3 years, and 18.6% between 3 years and 5 years. So only if you calculate that way, the computation comes to 12% fully immunized, whereas 74% not immunized. And surprisingly, we don't have it in the UIP as well, the varicella vaccine. So the key message that comes out of this is that a significant proportion of children are affected, adolescents and adults are susceptible in India, and varicella complications are increased in the higher ages. So varicella seroprevalence rates of greater than 90% are only reached by the age of 30, and we need a proper vaccination strategy. So why the vaccine? Why should we vaccinate at all? In this background, you see it prevents disease, it prevents severe disease, it prevents complications, and it prevents the fatality in newborns and neonates. So once we have talked about this, let us now find out what we have in store. So the history of the Oka strain, Oka name came from a family name, like I am Bhattacharya or you are Pandharikar. So the family name of this 3-year-old boy was Oka. And this fluid, which was used to develop the Oka strain of varicella vaccine, came from this boy who was a typical case of chickenpox. So we have till date only one strain, the Oka strain of varicella available. However, varicella vaccines in use today are all derived from the original Oka strain. But what is the difference then? The virus contents, the other contents may vary from one manufacturer to the other. So what does ACVIP recommend? ACVIP recommends that for a vaccination, we have a minimum age of 12 months. We administer the first dose at 15 months through 18 months and a second dose 3 to 6 months after the first dose. So that is a change in the immunization recommendation by IAP. All high-risk children should, however, receive 2 doses, not after 3 to 6 months, but 2 doses 4 to 8 weeks apart, irrespective of the age. And what about catch-up? For children aged 12 months through 12 years, the recommended minimal interval is 3 months. For 13 years and older, the minimum interval is 4 weeks. During an outbreak, of course, the recommendation is that the first dose at 12 months, if it is ensured that the second dose will be taken, and the second dose after 3 months of the first dose. Now, why 2 doses? See, when we talk about 2 doses, remember, literature to date indicates a relatively high rate of primary vaccine failure and the limited evidence of secondary vaccine failure after 1 dose varicella vaccine. This suggests that a short interval between the 2 doses might be preferable in countries considering implementation of the universal varicella vaccine to reduce breakthrough varicella. So you can see over here, after 1 dose, we have a seroconversion of 86%, whereas after 2 doses, it increases to 99%, and the efficacy for moderate to severe disease increases to 100%. So administration of 2 doses improves the seroconversion, results in higher GMTs, and it is a superior efficacy against the disease with 100% against moderate and severe disease. It reduces the incidence of breakthrough varicella as compared to a single dose by 3.3%. So having said that, we have now given 2 doses. But why, when we used to give between 4 to 5 years a second dose, why do we reduce it to a shorter interval? So when we say to a shorter interval, remember, globally as of now, at the end of 2018, 36 countries have included the varicella vaccine in their NIPs. We have not done so in India. And not only that, studies have been published which say that there is a lot of breakthrough. Remember, in India, what is the age at which the children join preschool? 2.5 to 3.5 years. And if you are giving a second dose at 5 years, you have not vaccinated the child totally. So you are increasing the chances of exposure and breakthrough varicella as well. Moreover, not being in the UIP, recommended only by IAP, the uptake of varicella vaccine again is very, very low. So thereby again, the child is having a more exposure, unvaccinated, no antibodies, and therefore a varicella vaccine, even if the child has had 1 dose. So remember always, since our aim is varicella vaccine to give the best possible protection, we have to give 2 doses and over a shorter period. So this is the study which says primary and secondary failure. In fact, we have many studies. So ACVIP also says that special conditions where you must give the varicella. Yes. Where you have to give. There are several contraindications which we have already mentioned in our textbooks. So the best prevention we understand is timely vaccination. So if we have to give vaccination timely, then remember that we must see whether the vaccine exists, has a long shelf life. Yes. When we talk about Monkeypox, the shelf life is higher than all the other available in the market, which is about 36 months. And the vaccine with Trehalose stability data on long-term storage at 2 to 8 degrees is over 3 years. So the shelf life is higher, and I've depicted here that the enhanced shelf life with the varicella vaccine Monkeypox with Trehalose. Another thing is that whether there is thermal protection, whether there is chemical protection, whether there is a pressure protection, and what about anaphylaxis. So when we talk about thermal protection, remember proteins which do not get damaged when freeze dried but get denatured and degraded, they lose their functionality. With Trehalose, it is all retained and 98% of the protein is entrapped. So even at 70 to 80 degrees centigrade, Trehalose could retain the secondary structure. So it is not thermo unstable. What about the other things? You see anaphylaxis with gelatin and anaphylaxis with monosodium glutamate present as stabilizers in the other vaccines is there. So gelatin, again, it is the most anaphylactic of all vaccines, and 80% of the children who get anaphylaxis have been found to have anti-gelatin IgE antibodies. So is with monosodium glutamate in vaccines, and ACVIP says it causes headache, numbness, tingling, palpitations, and drowsiness. So intense generalized immune system reactions can be found with MSGs. If you remember the MSGs in Maggie, you remember how it was banned and by the government. So MSGs are very, very bad as stabilizers. So these are a few Indian studies which show safety and efficacy and serover conversion with Trehalose and vaccine. With Trehalose, there are international clinical trials. Over 2 lakh plus subjects of different age groups have been studied, and Monkeypox has good immunogenicity and safety in these trials. So the conclusion is that we have significant disease burden in India. The morbidity and sufferings of grown-up kids have to be taken into account, and school absenteeism. Remember, school absenteeism is something now that the schools have opened after 2 years of absenteeism. We need to look into the fact that the child needs almost a rehabilitation into the schools. And of course, in the adults, you have a lot of economic and work loss, day loss, DALIs, and high coverage, therefore, is the key. So recommended is vaccination with varicella, and varicella vaccine with Trehalose seems to be the answer. Thank you so much. I'm using varicella vaccine. Are you using it? If not, do use the varicella vaccine. Thank you so much.
Thank you, ma'am, for the very lucid and detailed presentation. I'm sure it will be of great help to all pediatricians who have attended the lecture. Thank you very much. I thank you on behalf of IIP Raigad.
Thank you so much.
And now we move on to our next lecture, that is case-based approach to exome sequencing. Friends, genetics is a branch of biological sciences that has progressed by leaps and bounds in the last 2 decades. It is of special interest to us pediatricians because we are in a special, unique way to diagnose, study, intervene, treat if possible, and most importantly, provide information to prevent the genetic disorders in the future generation. Without wasting much time for this vast subject, we have a panelist. I would like to introduce Dr. Prakash Vaidya, the moderator of the session. Sir is a practicing pediatrician since 32 years, affiliated to Fortis Hospital, Child Health Clinic in Mumbai, co-convener and writing committee member of Under 5 Bees and Asthma training modules, national trainer for the many IIP modules, past president of IIP, and many presentations and publications at many IIP conferences with me. Next, we'll go to the panelists. The first is Dr. Bajaj, founder and director, the Purple Health Clinic in Mumbai, presently affiliated to NHSRCC Children's Hospital, Sir H.N. Reliance Hospital, and Saifi Hospital. She is the founder and scientific advisor for a support group called PEHEL, which is an initiative for Down syndrome children. Special interest in pediatrics and perinatal genetics, dysmorphism, and IEM. Madam has received multiple awards for her articles and the chapters in IIP journals. Second of our panelists is Dr. Parag Tamankar. Sir is a senior consultant medical geneticist at Med Genome Labs, Bangalore, and Center for Medical Genetics, Mumbai. Sir is the first GM medical geneticist to practice in Maharashtra, has 42 PubMed indexed publications to his name. Sir's special interests are in clinical dysmorphism, IEM, exome, and macrogenetic analysis. The third of the panelists is Dr. Mukesh Sankleja, sir, a senior pediatrician practicing since 20 years at Bombay Hospital Institute of Medical Sciences. Sir's special interests are in pediatric allergies, asthma, pediatric infectious diseases. Sir has more than 40 publications in indexed Indian and international journals, has been a faculty in large number of national and international conferences. The last but not the least of a panelist, I would like to introduce Dr.
Can't hear, no?
No, I think it's frozen. Eyes come back.
And Dr. Parag is not visible. Dr. Parag, your video is not on.
Parag, sir.
Dr. Parag is there in the panelist.
Okay, on my video.
Easier.
Okay, doctor.
Oh.
Ajay, can we start?
Yes, sir. Surely, sir. I'm just
Can you start sharing my screen?
Yes, sir.
Okay, is my screen visible to all?
Yes.
Yes,
is my screen visible?
Yes, yes, sir. It is visible, audible.
Yeah. Okay.
Very
good. Yeah, I will start now, with your permission. A very good morning to all of you. And I thank the organizers for this wonderful opportunity to share this podium with some of the finest geneticists in our area, probably in the country as well. The topic is a small tweak from what the topic was that was announced. This was discussed earlier, that this is about genetic tests and what the savvy pediatrician needs to know about them. So the first thing that any of you might justifiably ask is that as a GP, as a general pediatrician, how do genetic tests concern me at all? And I'm a GP like all of you. So most of us have the perception that these tests are too expensive, esoteric, have no practical value, and hardly change the management. Some of us might give it a thumbs down. But let me, friends, tell you about how this test concerns us as general practitioners, general pediatricians. Let's take two scenarios. One, you have referred a child to a consultant, super specialist like a neurologist or maybe a nephrologist. And the patient comes back to you and says, Doc, I've been asked to do this genetic test. Should I do it? And you will say, yes, take the easy way out, do the test any which way. But even worse, he does the test and then he comes and puts the report on your table. And you see all kinds of unintelligible stuff like variant of uncertain significance, double heterozygote. And the patient tells you, doc, tell me what all this means. Well, the time has come when we should all know about this. There was a time when many of us were computer illiterate. Today, everyone is tech savvy. I would say the time has come to be genetics savvy too. And we should all understand the language of genetics. And for that, this is today's roadmap. What is the roadmap for today is that we will understand foundation facts. We will understand when I should ask for genetic tests, what are the tests, what are the limitations in practice. We'll have a case-based discussion of genetic tests in clinical practice, and we'll have something to do about how to counsel the family. And for this, I have a who's who of genetics in this part of the country. These people are all well known, and their credentials have already been discussed. And I'll go straight to my first question. That why talk of genetics? What is the burden of genetic diseases in our country? And I'll request Dr. Shruti to give us her opinion.
Yeah. Good morning, sir. And at the outset, I'd like to thank Mahapedicon for this platform. And thank you, sir, for this question. I think, the answer to this question starts with the European Union per se defines rare diseases, anything which is at a prevalence of, say, 1 in 2,000. Now, that's where the misconception is, because if you take the total burden of genetic disorders, it is 7 in 100, which is equal to 140 in 2000. So the cumulative incidence of all genetic disorders put together, collectively, these genetic diseases are not rare. And 80%, in fact, of the so-called rare diseases have a genetic origin. They occur in the first year of life. India is no exception to the burden of these genetic diseases, given the high population, the popularity of marriage, marrying within cousins in some communities, consanguinity, and the practice of marrying within the same communities, which is called as endogamy. All these make our country a sitting duck really for these genetic disorders. And the figures say it all, that India is home to 1/4 of the burden of rare diseases across the globe, with nearly 70 million individuals from our country suffering from rare diseases. And
point well taken, Dr. Shruti. The burden is very common. I would ask Dr. Parag to tell us, why are pediatricians and neonatologists responsible for their detection? I mean, why are we holding the baby? What do you say, Dr. Parag?
Yeah, as it has been pointed out that the genetic diseases, although rare individually, it's collectively common. And the majority of diseases, if you see, are present in the pediatric and the neonatal age group. So, for example, even at birth, when the child is born, when we have to declare sex, if there is a disorder of sex development, like ambiguous genitalia, then there is again a genetic disorder that is at question. Then in the screening for the disorders for which are detectable by newborn screening, we have a window of a period where we can intervene and prevent mental retardation or irreversible brain injury to many of these patients. Just like, for example, in the case of hypothyroidism, which is a very common disorder, the congenital hypothyroidism, the incidence is in various populations 1 in 1,000 to 1 in 2,000. So if we detect this and then intervene by giving very simple measures like thyroxine, which is an inexpensive tablet, we can make this children normal for life. That's the reason.
So as pediatricians and neonatologists
have to be important, have to be well aware of these disorders.
So the buck stops at us, I think, to detect and to go ahead. And Dr. Chaitanya, is there any other age at which genetic disorders can present, or they are only in the neonatal and pediatric age group?
Thank you for the question, sir. We are aware that though genetic disorders most commonly present in the newborn period and in the early childhood, but there's no age bar. We do have cases of muscular dystrophies or spinocerebellar ataxias which can present later. I can give you an example of a lady with postpartum psychosis who presented with citrullinemia. So citrullinemia in a homozygous state presented so late because it was a milder mutation, and also a very recent case of spinal muscular atrophy being diagnosed in a 60-year-old grandfather. Essentially, post-fracture, he was unable to walk. So when he was investigated, he showed muscle weakness, and later on it was known that his grandchild suffered from spinal muscular atrophy. So there's no age bar, and we need to think of genetics at any age group.
So in a way, what we missed probably gets presented later on to the other physicians. So as pediatricians, we all know about karyotype for a very long time. We are familiar with karyotyping. What is the meaning of all these terms? Microarray, NGS, clinical exome. And Dr. Shruti, can you please help us to realize what these terms are and explain to us?
So karyotype was, it is the like a one-time shot taken of all the chromosome materials put together. When we go to fish, it is more of a definite test which is targeted to specific chromosomal areas. So both karyotype and fish, when we compare it to the new age genetic tools, they are relatively macroscopic. In other words, errors which are smaller than this would get missed. And that's where the new age heroes come to rescue in the form of microarray, also known as array CGH, and exome sequencing. We will be having case discussions to explain this basically, but they are just new age tools which are simply giving us a more in-depth analysis of the errors and helping us get a diagnosis.
Perfect. These are much more refined tools than the karyotyping and the fish, right?
Yes.
So maybe you could carry on. What is the meaning
I
of
would like
this?
to point out here, sir, once again, I would like to point out here, so if the gene is like a book, then counting the chapters of the book is karyotyping, counting the pages of the book is microarray, and reading the book is exome sequencing. So in fact, we have to find an error, a misprint in the book. So this is the way we can describe it.
Yeah, so perfect. I mean, that is exactly what Dr. Shruti has illustrated in these slides, that if a book is missing, it is chromosome. If a page is missing, it is a chromosomal microarray, and spelling mistakes in the pages, next generation. So each is a more refined version of the other. And Dr. Shruti, I will ask you to elaborate it further and make it even simpler for us, please.
Yes, sir. So this is like as though if we were to take a cell, remove out the nucleus and unwind this wool of genetic error, there are errors at multiple levels. And then there are tools at those respective levels to pick up these tests. So at chromosomal errors like Down syndrome, Turner syndrome, maybe even DGeorge, these can be picked up by karyotype and fish. But when we talk of sub-microscopic, sub-chromosomal errors, micro-deletions, micro-duplications, we need microarray for that. Next thing, please. And for gene-level errors, it is what we need as next-generation sequencing. And in the next slide, I've just tried to take an example of a grammatical sentence where we just say, give me the book. If I was to delete or duplicate this entire sentence, this is like a large error which can be picked up by karyotype or fish. But if there is a sub-microscopic deletion or duplication, I need a more refined tool in this regard. Usually it is a chromosomal microarray or MLPA or PCR tools which may come to rescue. And of course, as Dr. Parag rightly alluded to, that if it's a spelling mistake, if give me a book becomes give me a boot, these are single nucleotide variations, typically the examples being thalassemia, cystic fibrosis, where these two tests of karyotype microarray would not be useful. Rather, we would need the next generation sequencing.
Perfect. It's like a microscope where you go into higher and higher focuses and higher powers to delineate the micro errors. And that's a wonderful explanation by all three of them, that what does each test actually look for. But again, as we hear of this jargon, exome and genome and exon, intron, Dr. Chaitanya, can you explain to us what all these terms mean and make it simple for us?
Mentioned that 46 chromosomes form the basics. Now, these 46 chromosomes contain about 20,000 known genes. These constitute something what is called as an exome. So essentially, whenever we are reading the exome, now each gene contains portions which are coding for proteins. These are called exons. The intervening segments, which ideally do not code for proteins, but they may have some regulators and promoters and splicing elements, they are called as introns. Usually when we are doing an exome, we are removing out the, as it's shown in the figure, we are removing out all the introns and joining all the exons. So essentially, if a big apple is like a genome, when we are doing an exome, it's only 2%, which is a very small slice of an apple. So essentially, the whole genome constitutes all the genes, which include their coding as well as non-coding and all the intervening segments as well. While exons, it will only code for protein coding regions. But when we are doing an exome, it will pick up about 85% of Mendelian disorders or in conditions as such.
So exome is primarily responsible, but however, introns do matter in some ways, right?
That's right.
Would you go along with this? That
So essentially what happens is whenever we have these exons, now the exons, the introns do have the splicing element. So when the exons have to be spliced out, the cutters or the scissors are there within the intron. So sometimes mutations at these boundaries can cause whole exon abnormalities, and that these sometimes may be missed on the exome. So these would require genomic testing, the whole genome testing.
But an exome sequencing primarily means studying the exon, which is only 2% of the entire genome. Is that true?
That's correct. That's correct. Absolutely.
Yeah. Now, how do we look at the genome? Dr. Parag, can you explain to us, how do I look at the exome? What are the ways of looking at it? And what is the difference between Sanger and NGS?
So basically, when we are looking for spelling mistakes, we have to target the regions which are more maximally concentrated with spelling mistakes. Those are the exons and the introns. So traditionally, if the genes are small, just like thalassemia, for example, where we have only 2 or 3 exons to be sequenced, then we can use a Sanger sequencing, which is the conventional sequencing invented by Frederick Sanger right in the 1980s. Whereas the NGS, which is massively parallel sequencing, is that we fish, as with the very well illustrated in this photo, we are fishing for many fish at the same time by putting a large net. So we have a chip which sequences millions of nucleotides at the same time, and then we can sequence all the genes. For example, retinitis pigmentosa, which has more than 45 genes, we cannot sequence each gene at a time because it will be very cumbersome and expensive.
So when there are few associated genes, you focus on the Sanger, and when there are multiple genes, you go for the massively parallel sequencing. Is that right?
That's correct, sir.
Yeah. Is it a slow process, Sanger sequencing? Because I read somewhere that an entire human genome would take 60 years to do by Sanger, whereas in NGS it is very fast.
Yes, it is very time taking because we cannot sequence more than 1,000 letters at the same time. So if you see, we have 35 million letters. So it will take such a long time for sequencing at 1,000 letters per read.
Wonderful. Yeah. So, Dr. Shruti, would you say, are there any advantages of Sanger versus NGS?
Of course, sir, that, actually as the technology of NGS is improving, these advantages of Sanger are relatively coming down, but still today Sanger is more robust. And if you get a if you get a variant on NGS, you would want to confirm it on Sanger. There are exceptions to which say that if a read or a variant on NGS has been checked more than 40 times, or what we call as a depth of more than 40 times, maybe a Sanger may not be needed. But in general, Sanger still is the gold standard for confirmation of a variant that you get on NGS, sir.
Okay, wonderful. So what are the options in NGS? Could you please just quickly explain this?
So I think we just go in an ascending manner. We have focused panel. So where you know your clinical diagnosis, say I have a case of Joubert syndrome, which is caused due to one of the known 34 genes, I would just ask for a focused panel. And of course, if it's a clinical exome or a whole exome, that's more when you have specific phenotypic handles, but really your confirmed diagnosis could be a lot of differentials. Clinical exome and whole exome differ that clinical exome may contain genes of 5 to 8,000 in number. They are OMEM-curated genes, whereas whole exome, as Dr. Datar said, look at the coding part of all the 21,000 genes. And of course, on the top of the ladder is a whole genome that's sequencing the entire apple together.
So as I understand, it's only the cost limitation that makes us opt for one of these, or is there anything else?
I think, sir, in short, the more deeper we dig, the more vast we go, the chances of unwanted information, uncertain findings will always increase. So always the age-old adage that, you stick to, if possible, the as per the indication, the most narrow bandwidth. Of course, if it's an unknown spectrum, you're justified in going wide.
flooded with useless information that you don't know what to make of. Would the other two geneticists, would Dr. Chaitanya and Dr. Parag want to add something to this before I move on into the cases?
At one point here, essentially what Dr. Shruti is suggesting, that if we are having or if we have reached a clinical conclusion, so after the clinical examination, we should ideally reach to some conclusion, or we should have some differentials in mind before considering these tests. So if we have narrowed down on the differentials, it's always better to go for focus panel or clinical exome. But if the differential diagnosis in our mind is very wide, then in that case, you could opt for the larger panels as such.
Wonderful. Anything to add, Dr. Parag?
So sometimes even the time required for test takes one of the decisive factors. For example, if you are doing a prenatal, then you have very limited time, for example. So we can choose a test, for example, like a targeted sequencing. If you have a very genetically homogeneous condition, which we'll discuss later, where we have founder mutations or hotspot mutations, we can do that hotspot mutation analysis. Because in our country, many times because of lack of awareness, patients present in state where they're already pregnant, and you have 2 to 3 weeks to make a diagnosis.
Right.
Whereas a NGS test would take at least 4 weeks.
So we'll go on to some cases which will illustrate these points. Now, I think Mukesh has been quiet for a very long time. So Mukesh, I would like to ask you, what are the questions you will consider before you will subject your patient to a genetic test? Mukesh? Hello.
Yeah. So Prakash, as a routine pediatrician, the single and most important thing that I would do first is to take a good family history, build up a good family tree, take a detailed history in terms of all the clinical symptoms, do a thorough clinical examination, and subject the child to the initial gamut of investigations, be it biochemical, be it imaging, and then form a good clinical phenotype, because that is the single most important thing that will guide me to the choice of the test. Let me give you an example. If you have a child with global developmental delay or intellectual disability, I classify these children into 4 groups. The first group is the child who has clear-cut birth asphyxia, who has a prolonged second stage of labor, delivered and went on the ventilator, and he had neonatal convulsions.
So that's obviously not genetic. So that clearly is non-genetic, right?
Yeah. So this group of patients, I would not investigate on a genetic front unless there is some congenital malformation, there is consanguinity, there is previous child who is affected. The second group is the one with inborn error of metabolism suspected. You have hypoglycemia, you have neonatal convulsions. This group, initially, I would do an IEM screen. Eventually, probably a genetic test would come in. Okay. The third group is a group with dysmorphology and multiple congenital malformations. This child would straight away go for a genetic test.
Wonderful.
The fourth group is a group with global developmental delay or intellectual disability, where there is no clinical clue. There is no neonatal event, and on history examination, there is no clue on examination. Now, this group, as a general pediatrician earlier, I was at a loss. But this is the interesting group where use of genetics tests has come in big time. So basically, a good clinical evaluation will decide which test I will choose, and then, of course, the cost, as Chaitanya said, the duration for which the test runs.
So before I go on to the platter of cases now, what does each of this cost? I mean, Dr. Shruti, can you tell me what would an exome testing cost in Mumbai, for example?
That there are labs, multiple labs, and again, maybe depending on a whole exome, now the rates are really down, but anywhere between 25 to 35, 40,000. Even if you take the whole spectrum of the labs across the international ones, the Indian ones, but between, and in fact, some of them in extreme circumstances may even bring it much lower to around, say, 22-ish thousand, so in exceptional
so
situations.
It's not as expensive as it is perceived, and it is doable to most parents, right?
Yes, sir.
Yeah. Okay. So now, thank you very much. Now we'll go in, as Mukesh pointed out, the right phenotype is required. It's like doing a literature search. The more precise your search terms, the better your yield. And now I'll go on to a platter of cases that we have for you. Let's take the first case. It's a 7-year-old boy with motor delay, with frequent falls while running, difficulty in getting up from the sitting posture, abnormal gait, swelling in the calf region, Gowers sign positive, CPK 3000 units per liter. And of course, no prizes for guessing. Mukesh, what is the diagnosis straight away here?
Yes, so you're looking obviously at a muscular dystrophy. And since the presentation is little early, it's more likely a Duchenne's muscular dystrophy on the phenotype.
Yeah. So what next will you do in this child?
Yeah, there was a time when we used to do the EMG nerve conduction workup for a muscle biopsy. I think with advances in genetics, once your phenotype is reasonably sure that this looks like a Duchenne's, or even if it's subtly there's a differential diagnosis, genetic testing is what comes in straight away.
So straight away you will go for a genetic test. You will not waste your time doing EMG and biopsy and nerve conduction studies, right?
A genetic test on peripheral blood.
Does it give me an unequivocal diagnosis?
Depends on what the results come back as. So the commonest cause is a large deletion or a duplication, in which case if you run MLPA, you would get the diagnosis in almost 2/3 of cases. In a small subset of cases, there may be smaller mutations, in which case we may be forced to do a further test. But if this test comes positive, your initial screening of MLPA, you are sure it's a Duchenne's or a Becker's.
I will show this report to Dr. Shruti, and this is what the report has come. If it's not readable, I'll make it focused. There was a hemizygous deletion of exon 44 detected, MLPA ratio probe 0.0. Can you just explain to us what all this means, please, Dr. Shruti?
So when we say hemizygous, it means that obviously in a male proband, when there is a deletion on a X chromosome, the term used is hemizygous. Deletion is, of course, that some part of the gene has got deleted. Where is the deletion on exon 44? MLPA probe ratio. So MLPA in very simple language is a test which gives us the dosage of the given gene. A ratio of 0:0 indicates that that gene region is absolutely deleted in the proband. And when we speak of classification, in a descending order of certainty, there are 5 tiers which are given by body's ACM gene, by which the geneticists abide to, pathogenic being the highest and of most certain classification, followed by likely pathogenic. Third comes variant of uncertain significance, then likely benign and benign. So here the classification is pathogenic, which means that the proof of causality is of the highest degree, and we can be rest assured that if the phenotype is matching, we have confirmed the diagnosis.
So what test, as a general pediatrician, what test should I ask for when I see a suspected muscular dystrophy?
So here, although there are options, people may go from narrow to vast, like there are hotspot mutations, common mutations, but I think with the cost of MLPA coming down, MLPA looks at all the exons of the DMD gene, and the cost may be lesser than 10,000 or 11,000 in most parts of the country. I would directly go on for an MLPA for the DMD gene, sir.
Okay, so wonderful. I just tell the lab that I want an MLPA and I'm suspecting a muscular dystrophy, right?
Absolutely, sir.
Yeah, and it will tell me the difference between a DMD or a Becker.
So this requires genotype-phenotype correlation. Or there are occasions when it may be able to tell you if it's an out-of-frame deletion and that's correlating with your severe manifestations. But sometimes the same may not be evident clearly based on the genotype alone. And you may have to kind of follow up the child to see where on the spectrum is he falling.
Okay, but at least it gives you a clear-cut diagnosis.
Yes.
Yeah, Mukesh, anyone wanted to add something?
I'd like to add one point, sir. We have something called DMD frame checker, which is very readily available. It's like a jigsaw puzzle. So essentially, the puzzle is fitting, essentially the connotations are fitting into each other, then we call them as a in-frame type of deletions. But if it is not fitting, they're out-of-frame deletions, as Dr. Shruti was mentioning. Okay. So these are readily available, and exon 44 is one of the phenotypes pertaining to DMD because it's an out-of-frame type of a deletion.
So if it's out of frame, it's more severe. In frame, it is less severe. Is that what the interpretation
because
is?
essentially,
usually.
Okay, excellent. And now, Mukesh, you already mentioned that muscle biopsy and dystrophin analysis. Sorry, yes.
Just a minute, sir. In this, only one exon is deleted. So we have to confirm it using an alternative technology. The reason here is that sometimes the probe may not be able to bind because of a polymorphism in a particular region.
Okay.
So usually if 2 exons are deleted, then we take it as directly pathogenic. But only if 1 exon is deleted, we may have to confirm by using multiplex PCR or sequencing to show that there is no polymorphism in that region.
Okay. As a clinician, Mukesh, you said that muscle biopsy and dystrophin analysis have become obsolete. Is that right?
Actually, obsolete is not the correct word. But Prakash, I would rather say it's used in a very small subset of patients. Okay. If your MLPA is negative and you check for a small mutation that is also negative, but your clinical phenotype is very strongly suggestive of Duchenne's Becker's, in that case only, in a very small subset of patients, would a muscle biopsy and a genetic analysis on the muscle be useful.
Point well taken. So it's only used in a small number of cases. With that, we will go from muscular dystrophy to the next reasonably common case that pediatricians and neonatologists see. And here I have a neonate day 3 full-term LSCS, no birth asphyxia, but the baby was floppy and started having feeding difficulties, became apneic and needed non-invasive ventilation. And my antenatal clues were that the baby had the mother had polyhydramnios and had poor perception of fetal movements. So with this clinical picture, Mukesh, what are your thought process immediately and what tests will you do?
Yeah, so you have a floppy infant, and if you look at the etiologies in a floppy infant, if you have a sick child, it could be sepsis, it could be one of the inborn errors of metabolism. You have Tay-Sachs, carnitine, glucose, glycogen storage. Then you have genetic disorders. You have trisomy 18, 21, 13, achondroplasia, Prader-Willi. Then you have anterior horn cell diseases like spinal muscular atrophy. You have endocrine diseases like hypothyroidism. So your list of differential diagnoses at this stage is a long list. So once again, you go back to the basics. You do a thorough clinical examination, do your basic tests, do a good clinical look at the reflexes, see whether the absent reflex still is an anterior horn cell disease. So your first step is, once again, you go back to the phenotype.
Point taken. If your phenotype is well defined, what is the test? Will you ask for a genetic test here early on?
Yeah, that's a difficult question, Prakash, to answer. On day 3, would I ask for a genetic test? Probably not. But if in the next 24 to 48 hours, I find no clue anywhere, neither in the antenatal history, not in the family history, not in the examination, not in the initial investigations that come back, then yes, probably I would ask for a genetic test.
So now this was the test with some idea. This was a MLPA done, and this was the kind of report that we got. And Dr. Parag, please interpret this report for me, because I can't make the head or tail of it. What does it tell us?
So here we are showing the imprinting disorders. So for imprinting disorders, one of the tests is methylation sensitive MLPA, because here the problem is in where the gene is deleted, whether it is on the paternal copy or the maternal copy. So you have two disorders, Prader-Willi and Angelman, and Prader-Willi can present as a floppy infant. So for Prader-Willi, many of the cases, in 80% of cases, we have deletion of the 15 chromosome on the paternal chromosome, 15q11 to 15q12 region. So this region has, as you see normally, this is the MLPA, which is showing a quantitative PCR. The heights of the probe, if it is equal to 1, then there are 2 number of copies for each gene. If then after methylation sensitivity by using an HHA enzyme, we see that normally some probes there are reduced to 50% of the levels. So if the initially only in this region, if you see initially only there is a large chunk which is showing only 0.5 copy, that is only 1 copy, which means instead of 2 copies there is 1 copy. And then we see that there is no reduction in this peak to 50%, which means there is only 1 copy which is methylated, and that is the maternal copy. So the maternal copy of the SNRPN gene, which is deleted, is normally methylated, and the paternal copy is unmethylated. So if you have the maternal methylated, only remaining the paternal is deleted is Prader-Willi. Contrast to this, if you see there is half copy deleted, but there is complete absence of the probe, then that which is methylation sensitive, then there is only 1 copy present which is unmethylated, that is the paternal copy. So this is Angelman syndrome deletion.
Okay, what I wanted to ask was, Dr. one of you, is that if I see a floppy baby, should I ask for an MLPA test if I'm asking for a genetic test, or should I ask for FISH first?
I think that is a common mistake that some of us tend to make, so that if, first of all, is the point to suspect Prader-Willi in a newborn who's floppy earlier on. This case was a real life scenario where we gave the diagnosis to the family on day 21 of life. Despite there being the typical so-called phenotypic features, what we say of almond eyes, small hands, obesity, hypogonadism, they are all seen after 3 years of age. In the first 1 to 2 years, it would be more of failure to thrive in hypotonia and feeding difficulties. So any floppy newborn with feeding difficulties, having ruled out the common differentials as Sanklesha sir was pointing out to, we have to early on order for an MLPA for Prader-Willi, not the FISH analysis, because only a FISH test would miss out 30% of the cases of Prader-Willi, sir.
That's a very wonderful point. Well taken.
So one more point for Prader-Willi. Usually these children may be born small and they have more of central type of a hypotonia, which is more common than the relatively the peripheral tone is much, appendicular tone is much better as compared to the central tone, and a very poor suckling, as Dr. Shruti mentioned. These are the common pointers towards the Prader-Willi, but there could be other differentials also.
So as the child grows older, the phenotype varies, and you may get a floppy baby later on. You may get the typical obesity that we know of with OSA, narcolepsy, hypogonadism. This is the picture that most of us have in mind of Prader-Willi. But let's not forget that in the newborn period, it presents as a floppy baby with feeding issues, sometimes with breathing issues. So with this, I'll go to another case. This is a child, and I'll just show the video. Mukesh, maybe you can take it up early on. Yeah, Mukesh, this is a child with hand movements and autism-like behavior. And if you were to see a child like this, what would you think of doing?
Okay, so this is a child who's come with, I assume, global developmental delay because there are autism-like features. And on morphology, there's nothing except for the hand-wringing movements. So this obviously warrants a genetic test straight away. So if there are children with autism or autism spectrum disorder, I think we are moving from the pendulum of missing and underdiagnosing autism to a phase where we are significantly overdiagnosing autism simply because there is no so-called confirmatory test. So any child with delayed speech, with poor social interaction is dumped into the autism basket and sent for counseling. Okay. I see very few children with any confirmatory genetic tests being done. Of course, the problem is that there is no single gene mutation that causes autism. Mm-hmm. There are many different mutations, and hence the stumbling block when you are testing genetically. But the bottom line is every child with autism must be genetically tested.
I'll be asking the geneticists about this too, Mukesh. That's a good point you made. But before that, just a quick comment on this kind of graph, Dr. Chaitanya. On this picture,
what we know is that Rett is a very expanding type of a phenotype. So wherein multiple genes which could be, causing Rett or Rett-like syndrome, they are also called as atypical Rett syndromes, because all of them may not have the typical or classical presentation of a normal development followed by a regression followed by plateauing. So that's the classical Rett, how it follows. But many atypical Retts may just present with autism or autism-like features and non-specific delays. So since the spectrum is expanding, the smallest, even the MECP2 variants also, there's a vast variant phenotype which is seen. Even in males, we are seeing MECP2 variants causing Rett-like syndromes. So being an expanding phenotype here, usually I try to classify autism cases into cases with syndromic and non-syndromic presentations. So those with syndromes are having some dysmorphology or intellectual disability in addition to autism, certain clues in the phenotype or neuroimaging which are indicating or hinting towards a specific cause, while the other set is completely non-syndromic type of autism, wherein they only have autistic features and no other major involvement. So usually when we're evaluating the syndromic cases, you're more likely to reach a genetic diagnosis there.
So there are multiple genes which are involved in this particular syndrome, right?
Right. And there's overlaps also. As you see, there could be epilepsy, there could be a regression of skills, there could be a lot of neurological involvement which may be noted in children, and therefore that particular the pie gram that is given.
So when autism is just one part of a multi-system of a multiple neurological issues, I think genetic test is the way to go. So I'll put this question which Mukesh has already answered unequivocally. Do we need genetic tests in every child with autism? And I would like each of you, Dr. Shruti, Dr. Parag, and Dr. Chaitanya, to give me a one-line answer on this. Starting with Dr. Shruti.
Yes, sir. So as per the current recommendations, every child with autism should be, worked up at least with the first test in the form of a micro-R, and if it's a male, an additional Fragile X testing. But the answer is yes.
Yes. What about Dr. Parag?
Yes, I do agree, because many of the patients will not have any features such as dysmorphism or any family history. So we cannot differentiate between a genetic case and a non-genetic case purely on the basis of autism.
And Dr. Chaitanya, you agree on this?
Absolutely, yes, because we are having cases with treatable autism, so essentially a case wherein there was a deficiency of the branch chain amino acid in a child presenting with intellectual disability and autism. We just supplemented this child with these branch chain amino acids, and it's a BC-CAT deficiency. So we now have treatable causes of autism and intellectual disability which have been defined. So an early diagnosis sometimes may help us in picking up the case, because that child has an older sibling who is absolutely intellectually disabled. But since this child was picked up young, we could initiate the treatment in this child.
That's very heartwarming. So I think it's a great take-home message that autism today, we should do genetic tests, which test Dr. Shruti has already answered. So I'll go on to my, they say that 50 to 60% of autism spectrum disorders have an underlying genetic etiology. And there have been studies by Ramaswamy and et al. Where that is also been borne out. But because we have more cases, I'll go on to my next one. So let me take another case now. This is a 16-month-old girl born of a third-degree consanguineous marriage, global developmental delay, no neck holding, no eye contact, absent speech, sleep disturbance, and seizures. So Dr. Chaitanya, if this patient were to be referred to you, what is the test that you would ask for and how do we interpret it? So this was the test I think the referring doctor already asked for, and we got this kind of report. But then how do you analyze the report and what do I do now?
See, that is what is the trend nowadays, wherein directly ordering exomes is become a fashion. So essentially, without doing any kind of phenotyping or evaluating. Now, if this child had come, so essentially we would have gone through a battery of tests, especially the clinical evaluation. What sort of delay was it? Any specific pointers on the phenotype? Perhaps an MRI evaluation, and followed by that a metabolic evaluation, and then going for a genetic evaluation is the ideal way to go forward. But this family directly came with a diagnosis, and they showed there were 3 variants which were identified. One of them was in the PTS gene, which gives rise to the BH4 deficient hyperphenylalaninemia, and the 2 others were pertaining to Alexander and Tay-Sachs. So if you look at these, essentially the first variant is in a homozygous state, is the PTS gene. It's a variant of uncertain significance. The second gene, the GFAP, is in a heterozygous state, and we know that Alexander disease can lead, essentially it's a autosomal dominant type of condition with a mutation in one gene. Well, the third one was not at all significant because Tay-Sachs cannot occur in a heterozygous state. So now after reviewing the child, we would consider for a proper phenotyping in this child. And when we did the TMS, this particular patient showed a very high phenylalanine level. So if this would have been done earlier, or perhaps on newborn screening, we could have averted all these issues at all. So essentially, a very crucial part is whenever we have variants of uncertain significance, we should try to phenotype that. MRI brain was apparently normal, and out of this, the PTS variant was classical. Since the MRI brain was normal, it ruled out Alexander and pertaining to the hexocyanosis disease. This is a very treatable disorder which we could pick up, and we could initiate the management in this child as well. But the point to highlight is, if you would have gone in serial order or perhaps considered newborn screening, this potentially treatable cause could perhaps have been identified.
You mentioned reverse phenotyping. What is this reverse phenotyping, and can you please tell us clearly and the importance of that?
Essentially, whenever we are going in for a genetic test, we should have some phenotype in mind. We should have some disorders in mind which we need to test, based on which the lab should perform the testing and analyze the data. But once you receive the result, it is necessary to go back and check with the phenotype, and that is what is called reverse phenotype. Now, one, it can be a physical phenotype wherein I'm comparing the dysmorphic features. It can be a biochemical phenotyping wherein I'm considering some biochemical test to confirm. Just to give a very short example, I had a homozygous PPT1 variant patient who had come to me for an evaluation. Now, PPT1 pertains to neuronal ceroid lipofuscinosis. Now, essentially, the child did not show any features of NCL, and it was a homozygous variant. So there's a simple test called PPT1 enzyme which was available, and that was bang normal. So that ruled out the particular PPT variant at all. And the third thing could be neuroimaging, or sometimes you can use X-rays to really phenotype these children and to give a confirmatory diagnosis.
So when you see a genetic report, you have to go back into the phenotype and see if it really, as they say, as every lab says, correlate clinically. Is that what we are trying to say? That unless we correlate clinically, we cannot judge anything. Yes, anyone?
Because the variants can come out as homozygous variants, sometimes in consanguineous couples. It comes out as a homozygous variants which have been inherited by descent. and these are not actually causative of the condition at all. And sometimes you may land up in offering a wrong prenatal diagnosis for these families also.
Absolutely. So the moral of the story is, do not go by the genetic report at face value. Interpret it only in the context of the clinical phenotype. And I've got one more case which will actually dramatically illustrate this particular issue. So I'm going on to my case 5. Thank you, Dr. Chaitanya, for those very clear remarks. This is a 4-month-old child, Ryan, non-consanguineous marriage, fever since 3 to 4 weeks, initially low grade, intermittent, progressed 100 to 101, but reduced without medication. And the child was active during febrile episodes, received empirical antibiotics before we saw him. Also, this child had vomiting for 3 weeks, moderate quantity, non-bilious, non-projectile, 2 to 3 episodes per day. Child had impressive failure to thrive. In terms of weight, height was okay. He was gagging on starting to feed. Developmentally apparently normal child, was also on formula feeds, and clinical findings were unremarkable. So let me quickly tell you about this child. Everything was negative, whatever you can ask for. Suck-rest cycle was not there. Poor feeding was there, but there was no suck-rest cycle. There was no altered sensorium, no CNS problem, nothing absolutely anywhere. To all practical purposes, this was a child with 3 weeks fever with feeding difficulty, infection or inflammation, associated GERD. So Mukesh, as a clinician, if you were to see such a child, what would you do next?
So obviously, these are alarming signs with failure to thrive. Clearly, there is a major pathology somewhere. And your entire history and systemic examination has revealed no clue. The first thing you think with fever is an infection. But your investigations have not revealed anything. You've given empiric antibiotics. So you need to...
Yeah, sorry. Yeah.
Yeah, so actually there is no clue on the history as to in which direction we are proceeding. So it's a tough call as to what next you would do.
So this was a child with 3 weeks of fever, not thriving well, and had gagging difficulty. That was really the most impressive part of it. So he was investigated in detail, and every test that you asked for, Mukesh, was within normal limits. All the inflammatory markers, the tests for COVID were done, COVID antibodies, tests like serum ferritin. Then because of gagging issues, he was subjected to bronchoscopy, and the bronchoscopy was normal. Immunodeficiency tests were normal. Metabolic TMS was normal. So we really drew a blank. So then with that, this was what we were thinking of. Would you agree with this?
Yes, I think with his fever and no infection, I think ectodermal dysplasia was very much on the cards.
Yes.
Thyroxine,
Again, he had no
I assume that
ectodermal dysplasia. He had no features of thyroid.
No hair.
Yeah, nothing at all. So with that, this child's clinical exome was asked for. I don't know whether you will agree with me, but this is what was done here. And the report was Ryan, born of a non-consanguineous marriage, presented with history of fever, choking, refusal of feeds, evaluated for pathogenic mutations. And this was the report that came, and a variant of uncertain significance was detected related to the given phenotype. Dr. Shruti, what would be your take on this?
I think over here now, the whole thing would be that, first, even though, as Dr. Datar was saying, that it's an autosomal recessive disease, first thing would be that whatever the disease has been offered, I would have considered a homozygous to be a more likely take. But having said that, I would still maybe just want to do a biochemical confirmation because it's simple and easily available. But I feel, honestly, the diagnosis could be elsewhere, rather than...
So you would not give much countenance to tyrosinemia type 1. It is an irrelevant...
yes, this could just be a distraction. Yes, sir.
Now, what happened was, I have hidden something from you, that that MedGenome did that report and they sent us a mail. And they also said in that mail that this is what they said: we have detected a hemizygous single base pair deletion in exon 3 of the AVPR gene. So they are telling us in effect that we have detected something else, but maybe your phenotype is mistaken. So this is something that we have seen, that unless if you hurry into a phenotype and you give them a wrong phenotype, you are going to get all kinds of irrelevant reports. So what happened was, we went back to this child and we found that, oh, we had missed something. His sodium was very high. Serum sodium was 154. And we went back to the clinical questions, and the parents said that there was no polyuria, but on careful monitoring, he had a urine output of 7 ml per kg per hour, which is by definition polyuria. And then we went back, repeated the serum sodium, and we did a serum osmolality along with urine osmolality, and now the penny falls. that the serum osmolality was 302, the urine osmolality was 113 with the same serum osmolality. And this is where we found that we got a fresh, we told them that this is what it is, and we got a fresh report. And now, Dr. Shruti, please tell us how to interpret this report.
So I think, sir, this is what happens, that as the phenotype improves, a data reanalysis can often then give us an answer. Now we can see that after your fresh reverse phenotyping and reanalysis, we have got a pathogenic variant, which is hemizygous, again, a single X chromosome on the head for a male child. And it is suggesting a diagnosis of nephrogenic diabetes insipidus, which we are now we have proof of causality, and I would consider this as a likely diagnosis, sir.
Okay. So this is what happened. We rushed into a clinical exome. We went on the basis of the previous phenotype, which was quite obviously not accurate. And the minute we gave a proper accurate phenotype based on investigations, we got a proper report. So the moral of the story is A, the importance of reverse phenotyping and the importance of phenotyping in the first place when you ask for a genetic test.
Just like to add, sir, there is something called evolving phenotype as well, which we need to be aware of, because sometimes the same condition may present early, wherein we may not have that particular phenotype being present in the child. But as the child grows, he or she shows more symptoms in that particular regard. And perhaps if you reanalyze that case, say 2 years down the line, it may fit quite well into the phenotype. So if we have such variants of uncertain significance, we do not ignore them clinically as well as the bioinformatically.
Just
we
follow
ask
it
for a clinical as well as the data analysis.
Okay. Thank you so much, Dr. Chaitanya. That's another insight. And the final diagnosis was revised. So genetic. So this really what happened is that genetic test may sometimes point you the right direction, and this is what happened in my case actually. So which
Prakash,
means
I suspect that this is going to happen more and more often with more and more wider availability, better awareness, and more affordability.
Absolutely.
The temptation to, as a clinician, to jump into genetic testing and then go back and look at the child is going to become more and more, I suspect.
Right. So I quickly want, we are running out of time and I have more cases. So as a general pediatrician, can I ask for genetic tests? So Mukesh, I just want a one word answer from each of you.
Yes, but only after you understand a little bit and attend more talks like this.
Dr. Shruti, Dr. Chaitanya and Dr. Parag, please.
Yes, but after even more sensitization, because a wrong label can do more damage than no label.
Absolutely. And Dr. Parag?
Yes, I do agree. We should have a multidisciplinary approach and try and involve, of course, there are scarcity of geneticists, but as far as possible, have another person guide you, because genetics is a rare diagnosis. Sometimes you label for a life. So it is no label better than a wrong label.
So I think instead of just asking for tests at random, we should always take the help of a geneticist and do the right thing. Do you agree, Dr. Chaitanya?
Yes, absolutely, sir. So phenotyping is crucial, and always I say start with the basics and go upwards. You should not forget the basics. While
Corollary to this is, if I'm stuck for a diagnosis, I'm getting nowhere in a test, should I do genetic test as the next step? And quite obviously, it is not to be done at random, because let us realize that genetic tests, like all other investigations, cannot be used as a drunk uses a lamppost for support, not illumination. They are to be asked for as a specific test with a specific phenotype in mind. So I think that's a good take-home message. And with that, we move to our next case. And we have this child who is, this is a spot diagnosis. And Dr. Parag, if you were to see this child, what test would you ask for?
So this child came with presentation of short stature. As we can see, there is rhizomelia. And the X-rays also do show that there is skeletal dysplasia. So I would suspect a common diagnosis like achondroplasia and would order the test for achondroplasia in this patient.
Okay. So can you interpret this test for us? What is the meaning of this sequence chromatogram?
So here, basically, we are seeing results of a Sanger sequencing, which is shown as peaks. So the nucleotides are represented by different colored peaks. The A's are the greens, the blues are the C's, the G's are the black ones, and the red ones are the T's. So here you can see two peaks overlapping each other, which means there is a heterozygous change. The normal, so this written as C.1138G2A. So the cDNA position 1138, the guanine has become an adenine, and the protein change is written as P.G308R, which means glycine. There's a misprint here. It's G380R. Glycine 380R position becomes an arginine. So this is a heterozygous change.
Okay. So this is a child who is ripe for a genetic test, and it was rightly done. I'll take one more dysmorphic child. It's a 1-year-old girl with a global developmental delay, facial dysmorphism, short stature, moderate VSD. For want of time, I'm not going to involve Dr. Mukesh because he's already told me that when I see a child with delay and dysmorphism, genetic tests are the way to go. So Dr. Shruti, can you tell me that here the pediatrician did ask for a genetic test and the karyotype was normal. What do I do now?
So in a constellation of multiple dysmorphic features where the etiology is inapparent, there are now unambiguous guidelines which say that chromosomal microarray should be the test of choice. In simple words, it's the smarter and the better sibling of karyotype. It just tells you the information that a karyotype would have told you, but at a resolution of nearly 100 to 200 times higher. It gives you the deletions and the duplications practically across the genome. And of course, depending on which areas are represented in the chip of the microarray. But yes, with a higher yield of 10 to 15% better as compared to karyotype with nearly 100 times better resolution, microarray is now the test of choice for a dysmorphic child without an apparent etiology. We ordered that, and rightly so, we got a 13q33 to 34 deletion, which was classified as pathogenic, sir, in this case.
Yeah.
The importance, of course, when we counseled about the diagnosis and we were reading back about the case, was that this deletion can predispose the child even to retinoblastoma. So we see how sometimes these diagnoses can give us information of practical importance much more than what we were looking at.
So
of course, there were other impacts.
As
Yes.
a message to pediatricians, I want to know that if I have a dysmorphic baby, should I straight away go for that high-powered karyotyping or what you call as a microarray, or should I do a normal karyotyping and then do more genetic tests?
Sir, I think I think microarray would be the test of choice if the
I would not
etiology
do karyotyping alone. I would go for a microarray straight away.
Yes, sir.
Prakash,
Do we have a
one
complete
comment?
agreement on all three? Yes.
Prakash, one comment then, where would I use a karyotype? So
Yeah,
if I'm
so
suspecting a clear-cut trisomy 21, 13, 18, delayed puberty, short stature, if I'm suspecting Turner's, or there's a single malformation.
Specifically, if I'm looking for parents with balanced translocations in scenarios of recurrent pregnancy losses, because that's something a microarray cannot pick up. But otherwise, yes, a microarray becomes a test of choice. There are exceptions, but I think we don't have time to
So
discuss.
dysmorphic baby microarray is the better test.
Yes.
Is that a good take-home message for us?
Absolutely.
Thank you so much. Yeah. So now my last case, because we're running out of time. Mukesh, this is quickly for you. It's a 5-year-old girl with adopted child, failure to thrive, hypoxia, bilateral course crepitations, purulent sputum, typical suppurative lung disease, TB negative gene expert ultra. The child had multiple admissions and the child had bronchiectasis. So it's a suppurative lung disease in a 5-year-old adopted girl with hypoxia. The weight chart was a mess. Her child really had failure to thrive. And she was tested for immunodeficiency. The DHR was negative, lymphocyte subtest normal. And even the sweat chlorides were not very kind of convincing here. It was a borderline test. It wasn't normal, but it was a borderline high test. So with this was the CT scan. And this is where, Mukesh, perhaps you would agree with me at this point, what test will you do when you have done the basic tests?
So your differential diagnosis is between cystic fibrosis, primary ciliary dyskinesia, and primary immunodeficiency. So you need to look into these three etiologies in greater depth. We all know the fallacies of a CFTR gene testing, where it tests for cystic fibrosis, but limited mutations. So similarly, so we need to go more into the depth of these three etiologies. We know that primary immunodeficiency screen, you may not get anything in the primary screen itself. So in all these three areas, you need to go more into depth.
So nowadays you get a panel, which I think one of the companies gives you, which you can ask for a specific kind of test for this. That means I want a CF panel, I want a PCD, and I want for, that is primary ciliary dyskinesia, and also for PID, primary immunodeficiency. So this is the panel. And I would quickly like, now this was the report we asked for, the exome analysis here. And this was the report. And Dr. Chaitanya, please comment on this report and tell me that, would I be right in asking for a panel every time, or was this just a hit and miss thing?
Here we have the exon 11, the common mutation, the delta F508. The other one is a heterozygous mutation. So possibly this could be in a compound heterozygous state, but parental testing is necessary to confirm the pathogenicity, because sometimes what can happen, both
But
these
here we could not do it.
mutations-
The child was adopted.
that then in that case it is the reverse phenotyping and the follow-up things that, but from the look of it, it does appear pathogenic. But here in these cases, I'd just like to comment, we would opt for clinical exome in such scenarios rather than looking for specific panels, because they would cover a wider number of genes, and looking at wider genes, we could look at the specific genes of our interest here in these cases rather than looking for specific panels.
So, sir, I just want I want a small comment from each of you, that if as a pediatrician I thought of suppurative lung disease, I thought of possibly PCD or CF or PID, can I ask for just a panel of these tests, and will I get a diagnosis with that? Like, as I told you, one of the companies does give you CF plus PCD plus PID. So how sensible is asking for such a panel? And I want each of you to comment, Dr. Shruti, Dr. Parag as well.
I think that's the same thing that we're coming back on, that if you're really suspecting these three differentials, as Dr. Datar sir rightly said, a clinical exome or a whole exome would be a better choice, because it's giving you a wider breadth of genes to cover. But you have to be doing it after a good, robust phenotyping pre and post-test genetic counseling. But I wouldn't really order for a panel in today's era. I would rather go for an exome sequencing.
Okay. What about Dr. Parag?
Yes, I do agree, because the cost is not very much different. Even the time taken is not very much different. So, so the cost of sequencing is decreasing day by day. I think panels are going to be obsolete one day.
So don't ask for panels, ask for a proper exome sequencing and just give them the phenotype and they will give you the answer. Is that what you're trying to say?
Yeah.
So just to save a few thousand rupees, do not ask for just panels. Is that is that the take-home message?
Yes, yes.
Prakash, your panel may not include all these CFTR mutations. It will
Right.
include, you need to go back to the panel and see if it is exhaustive.
One more thing would be the panels are not regularly updated. Sometimes the newer genes may not be picked up on the panels, while these exomes are typically updated regularly by the companies.
So I think all three of our experts are making it unequivocal that do not ask for panels wherever possible. Ask for whole, ask for the exome sequencing. Is that right?
Unless, of course, sir, the phenotype is very specific. If I have a maple syrup urine disease, I know there are 5 genes which cause it. I will ask for an MSUD panel. But in a condition like this, where the phenotypic heterogeneity and the etiological heterogeneity is such, I would order for a exome sequencing probably.
Okay, thank you. So I think this is what I wanted to ask. When are tests warranted, and do genetic tests help in avoiding invasive tests like lung biopsy? That is very true in particularly in ILDs, where you can actually avoid a biopsy and get a genetic diagnosis. So this answers many of our questions, that what use is genetic testing? Because I get a closure to the case. I get a diagnosis at any cost. I want a diagnosis, I get a closure to the case. I can even help in the next pregnancy by doing a prenatal test, and I have treatment when available. So before we end this session, I'm really thankful to all my panelists for giving us clear take-home messages. And I want to ask each one of them, from their perspective, a single important take-home message, a single one-liner before I have to wind up this session. So starting with Mukesh, give me one-liner on the most important take-home message for the audience.
A thorough, proper clinical phenotype and a good interaction between the clinician, the geneticist, and the lab.
Okay, wonderful. Dr. Shruti?
I think with great power comes great responsibility. We have to use the power of these newer genetic tests very responsibly.
Okay, great. What about Dr. Parag?
Sometimes it is wiser not to jump at a diagnosis, but to let the diagnosis grow on you, as Dr. Chaitanya has pointed out. It is a diagnosis based on time-tested methods such as phenotyping and proper observations.
And Dr. Chaitanya?
Genetic tests are going to be used very commonly, but a proper interpretation of the reports is also very, very crucial to guide them properly in the future for the treatment as well as prenatal diagnosis.
So in other words, you need to partner with a genetic expert. And I think that is one of the most important take-home messages here. It's not something that you can ask for. So let me just finish with some take-home messages. That clinical genomics is an idea whose time has really come. And we all in general pediatrics have to become genetic savvy. We should know what test to ask for. We should have the right phenotype to get a proper yield from the test. Advantages, of course, are closure on the diagnosis, change of treatment, counseling for prenatal diagnosis, and never label a patient with a disorder unless there is a clinico-test correlation. And that's something you need a geneticist for that. We need to learn how to counsel the family. This is part of the corollary of the same thing. And gene therapy, the future of medical treatment, the first step obviously is going to be genetic testing. So with that, we come to an end of this session. I think I was able to stick to the time. And I'm really grateful to all my panelists for giving very clear take-home messages. And I'm sure that they have given us practice-changing updates, which we all can utilize. And I'm also grateful to most of the panelists to give me cases which illustrated all this. Thank you so much. Yes.
Thank you so much.
Sir, thank you.
Thank you so much.
Excellent. Excellent job, Prakash.
Thank you. Thank you very much.
Thank
So
you,
I'll
sir.
Excellent job, sir.
stop sharing my screen now.
Sorry, sir. Please go on. Hello.
Right now.
So you want to say something?
Do we have any questions, or shall we go wind it up?
Sir, can I ask a simple question? Just
a quick one, sir, please. We are already.
I have listened to almost the second half of the discussion. The only thing is, is there any false positivity rate or sensitivity rate or all these genetic tests? Is there something like that as we have in the other laboratory investigations?
Here we have variants of uncertain significance that you may get actually. All variants are not really gene causative of a particular condition. So you may get really pathogenic ones which can cause the disease, or really benign ones which can never cause the disease. But there could be something called variants of uncertain significance which could go either ways.
Okay.
Thank you.
Thank you.
Okay. I would like to thank all panelists and the moderators for a wonderful session. I think for a general repetition, I'm sure this was an eye-opener and will provide a new approach to many of the cases, which will definitely lead to early suspicion, early diagnosis, and early referral, and also early treatment. I thank you all.
Thank you.
On behalf of Hrct, it was a really wonderful session. Thank you. With this, thank you, ma'am. Yeah. With this, now we move to the next session which is on Chai Pe Charcha. So, after many years of studying tirelessly, who does not want to be a successful doctor? We all do, don't we? But in today's world, it is just not enough to be good at one's area of expertise. There are many commercial decisions to be taken, right from the where to practice and the art of speaking to patients, answering on the non-clinical stuff. So, without wasting much time, to tell us more on these very important things in our private practice, I would like to call upon our next guests, Dr. Chetan Shah and Dr. Nirmal Choraria. Dr. Nirmal Choraria is Head and Department of Pediatrics, Chief Pediatrician Intensivist and Director PICU NICU, affiliated to Nirmal Hospital Private at Surat, and Madam has been the chairperson of Pediatric Intensive Chapter of IIP for 2010-11. Her area of interest are pediatric intensive care. Dr. Chetan Shah, sir, is the Chairman and Chief Pediatrics at Anand Children's Hospital and VP at Surat. Sir has been a Vice President for Central IIP 2020-21. He is an Executive Board member for 3 years, President of Academy of Pediatrics Surat, is for the National Coordinator for E-Gurukul CME, and has been organizing chairperson for many state health conferences. Now over to you, sir, for the next session. Please start the session. Thank you. Sir.
Thank you.
Thank you, sir.
At the outset, I would like, and we would like, myself and Dr. Chetan, to thank the organizers of Mahapedicon for giving us this opportunity of bring our experience of entrepreneurship in the field of pediatrics. Myself, Dr. Nirmal Choraria, started practicing before 40 years in Surat, and Dr. Chetan also started with the same time, maybe 2-3 years after me. And both of us, we are running a big private setup of a hospital. And here, as we were asked to share our experience, Chai Pe Charcha, about entrepreneurship in medical field. Now we understand that entrepreneurship means to have your own business and to expand your business to earn the money, and not only to earn the money, but to contribute to the society. Because by entrepreneurship, you develop the opportunities for the jobs for many people. But you are prepared to take the risk of entrepreneurship. So both of us, we started with a very small setup. We kept on taking risk at various fixed intervals and went on expanding our setup and employing more and more professionals and the people. So first I would like, so we will have a dialogue between myself and Chetan. So I would like to ask Chetan, like a chai pe charcha. Chetan, you are one of the senior most pediatricians in the city, Surat, in Gujarat, and maybe in our country. You are also practicing for more than 35, 36 years. And you had been in the IAP as executive committee member. This year you are the vice president. And with all this, I would like to know your journey as an entrepreneur, how you started and how you develop your setup.
So thank you. At the outset, I'll thank the organizers, Team Mahapedicon and West Zone Pedicon, for inviting us for this discussion. And just as Sir told, it is not just earning of money. That is, in medical practice, you can't exactly evaluate the returns that you are investing in the money form, form, because there are a lot of aspects to the medical practice. You know, there are some fields where you don't expect the exactly returns that you are investing. So here is one field where, as Sir told, we create a lot of jobs for the people. Similarly, investing our own profession gives a bigger hospital. See, we have been, both of us have been able to create big NICUs and PICUs which are state of the art in our area, and that has helped many, surviving many tiny neonates as well as the preterms or very complicated pediatric ICU patients. So it's a help to the society also. So many times when I started, I had that every 5 years, there was I was at the crossroads, whether I have to go further and invest more in the same profession, or whether I should sit with my own cash and invest in some other field and get more returns. Because as all of you know, medical field is not exactly as rewarding as you might invest in a gold or in a real estate, where your money multiplies many folds very fast. So there, every time I took a decision depending on the demands of the surrounding or demands of the day. Because when I started one, it was just a daycare center. Then after 5 years, I started a hospital. Then after 10 years, I got some good people to work for me. I thought, why don't I have a good neonatal intensive care unit, because I got some neonatal intensivists who will work for me. So then came PICU, then I started another hospital in periphery just because there was a demand. And of course, there is always some, role model where you follow. In Surat, where actually I have very good 2 role models to follow. Just one is, of course, Nirmal Bhai, who is just 3-4 years senior. And I worked with Dr. Bipin Desai, who again was the first one to start a pediatric multi-speciality hospital in 1980s. So those people gave me the insight into the, the business and how to expand. And I think looking at them, I gradually with their inspiration, I think I came forward and I could create a good team, good hospital, good facility where I can, devote the unit to the society. So that was, my journey with a lot of, halts in between. Every 5 years, I had that thought whether I should continue or not. So similarly, sir, you have also started with a very small nursing home. And now you are, in a biggest multi-speciality hospital, planning another 2 hospitals in Surat. So, I would also like to hear from you, what was your, journey?
Yeah. That's fine. Actually, Chetan, as you know, and to all the fellow colleagues and the delegates who are here listening to us. See, initially what happens, somewhere in the school, you decide to go to a medical profession, you select your vocation which you want to be. And once you come to the medical school, and that till you pass your post-graduation, you keep working. But somewhere you have something in your mind or in your heart that you think of some role models. First, it is your academic role models. You try to follow them. And then also simultaneously it starts with your survival mode. See, we all, once we get a degree, we are in a survival mode. We want to survive. We want to establish ourselves. So whenever either you are in a self-employed person or you are in a government or a semi-government, either in a job, but sometimes you feel that you should be self-employed, you should have your own business. And 80% of our medical services which are provided in our country are provided by the private practitioners. So to me, they all are entrepreneur, maybe a smaller level to a bigger level like Pratap Reddy, Devi Shetty, Naresh Tehan, and to many like that. So gradually you can start a journey with a small clinic or a small nursing home. So I started with a 9-bed pediatric hospital with only 3 employees, including me. I am a pediatrician, 1 staff nurse and 1 ward boy. So we were the 3 to start the 9-bed hospital in Surat. Today our hospital is a 120-bed multi-specialty hospital, and we are coming up with the 2 big hospitals, again multi-specialty and super specialty in Surat. So it was a gradual journey, as you said, every 3 years, 5 years, you keep on expanding depending upon the need of the location where you are practicing, need of the community. And I realized that critical care we have to start in Surat and in Gujarat as early as possible. So both of us started PICU, NICU work here. And not only that, you need to create a team to run your show. So in my hospital, before I started the fellowship program in 2008, NICU, PICU fellowship, more than 150 post doctors who passed their DCH and MD from various medical schools all over the country, they came to work with us to get that experience of critical care. And then in 2008, we started NICU, PICU fellowship. And in 2010, we started the DNB pediatric also. And we also started the CPS pediatric in between for 4-5 years. And you also have that fellowship program of neonatal fellowship going on in your institute for last 10 years or more. So both of us, what I feel that to be a successful entrepreneur, you need to visualize the things what you need to develop in your own field, maybe after 3 years or 4 years. So I would like to, Chetan, after explaining what I also did, what do you think what the requirement to become an entrepreneur? See, what should be a mindset of an entrepreneur? What should be the attitude of an entrepreneur? And what do you think are the challenges faced by the entrepreneur? See, what you face and what I face in the field.
See, when I started, I was, initially I was not inclined to start even a private practice because I was working with Dr. Bipin Desai, who was a very senior consultant. And at that time, I thought, if I continue with this, I can lead a good, happy life outside. But then somehow I was pushed into private practice. And of course, as you know, a good player may not be a good captain. So many times your good academics doesn't mean that you will be successful even in the business also. So these are the few things. And then once I got this, and then as I told you, every 5 years, there was a decision to be taken, whether I should go ahead or not. Challenges wise, first and most important challenge was to build up a team. And team, of course, all of you know, you cannot work everything alone, and building a team needs a lot of understanding on your part, because most of the young and budding pediatricians, they want their own nursing homes. So there was a need for a good team, and there I could find some pediatricians who wanted to work without taking hassle of running a hospital. So there I think a big scope was there, and most of them, they are very intelligent, they are capable of doing everything, but they just did not want to go into the hustle and bustle of running a hospital. So building a team, you need and find out such people who are very good academically, but they don't want to go into the practice. So there I found I have another unit where there is a working partner who has again a very bright boy, young boy, and he doesn't want to go into the hospital because they want to have a good life. Many of them, they don't like my way of life because I've been working so many hours. They don't want to do this. But so they don't mind working with a lesser sum also. So these are few, people who you can find out. Many other challenges are coming as the days progress. And of course, after a few years, the biggest challenges come from the, government schemes and other places where the rates have been less have been half. And I think Nirmal bhai, you are, having a big turnover in the government scheme also. So whether how many ways means how you overcome the the drawbacks of government scheme, how you have to bypass all these things and still run your business in private. I think you are having both the things, very good amount of private work as well as very good amount of government work. So how do we adjust to all these things?
Yeah, Chetan, I agree with you. And see, we realize, as I said you, that 80% of the healthcare is provided by the private practitioners. But equally important is that health services are becoming costly day by day because of many reasons for that. See, because we invest in the infrastructure, we invest in the equipment, we invest in the HR, and everything is getting day by day very costly. I remember the NIC when we started, we were offering 600 rupees a day. Well, inclusive of everything, their stay, doctor's charges and everything, 600 rupees a day. And Dr. Bipin Desai were also charging the similar, he used to charge the same. Nowadays, I think minimum 10,000 rupees for any tier 2 city or tier 3 city, 8 to 10,000 per day comes to the patient. It is the cost. And sometimes it may expand, go to up to 20 to 25,000 also. Because there are so many things which have come up new. So if you want to provide that kind of a quality care, right now the scenario is that 50 to 60% of our population cannot afford the private hospital charges. And government realizing this, that education and health is a topmost priority of every community. See, they have a right to have a good education and good health care. And that's why that PMJY, Ayushman Yojana was implemented, our Honorable Prime Minister, where 50% of the BPL below poverty line people are covered. And I can see, even visualize that maybe after 4 to 5 years, maybe 100% population can be covered with this. So we have to provide the care with the government norms and government laws and regulations. The challenge the face is that the government thinks that what can be the minimum affordable cost which government can also afford to provide to the quality people in private hospital. The biggest challenge is with the cost given by the amount given by the government schemes, how to provide that kind of a quality care. So we have to optimize our care. We have to control our expenditures. We have to provide it more affordable for the people so that we can also, the hospital can also earn something out of their what they have invested as a capital. It's a real big challenge, but positively what I feel, the government also understands. Our Indian Medical Association and the bodies like AHPI, Association of Healthcare Provider of India, and the regional association also means conveying to the government that you need to be more realistic. We don't mind providing the care. Yes, we are already providing it and we'll keep providing, but it's a big challenge. Definitely, there's no doubt about it. All the CGS rate and the government rate, the scheme rates has to be revised because the many insurance companies, they are still paying the rates of 2012 and 2013. With the inflation rate every year going to 5 to 6%, the cost should be double or triple by now. But still the people are being paid like 2013 or 14 charges. So it's a big challenge, but we all have to sooner or later accept this, that majority of the people coming to our clinics and hospital, they would not like to pay cash. They would like to have credit facility services either by the government or by the insurance company. or by their organizations or corporate sector. So it's a big challenge. I understand, Chetan. I think we have to work on it. But it is going to stay, and we have to optimize our services accordingly.
So another challenge that I thought was from the unorganized sector, because we have a lot of competition from some small quacks also, alternative medicine people. Then those there are a lot of other even social challenges. Means people don't like to pay high charges. There we have a lot of daily news articles that these people have looted so many. So more for 4 days they have charged so much. So a lot of social stigma is coming out, and people are talking bad about doctor community charging a lot. And there is again, as far as you are concerned, there is a corporate setup, a small town person or a small nursing home or a group one who have to compete with the small corporates. So how do a common pediatrician or a group of common pediatricians in a level 2 city can compete with the the power of a corporate?
Chetan, what I feel that what corporate is doing, number one, they are more professionalism in their services. Number two, they have a good marketing about their services, what they are doing. Unfortunately, we doctors and individual are not supposed to market our services as per the MCI rules and guidelines. And the corporates and the big hospitals can advertise about their hospital facilities and everything. See, I think now in this era, it should be open. Whatever you are doing, you should be able to display your services, your charges, and gradually I think NABH and all the NABH coming up, and all the hospital will be required to get accredited with the bodies and the Clinical Establishment Act. You need to display your services, make the people, public aware about what you are offering, and once you can communicate to the people what you are offering and what is the difference between your services and the corporate. Let me tell you, the corporate, their cost will be always high, 25 to 30% because of their setup and what they are planning. So if your expenditure, your investment is less than the corporate, if you can save 25 to 30% of the cost, we will be able, without corporate, to offer at a better level, better services to the hospital patients. See, so the corporates are going to stay, the government schemes are going to stay. We private practitioners, whatever level, small nursing home. See, people many times fear that small nursing home will be wiped out. No, it's not that. Clinics and nursing home are going to stay. What is the requirement of our country is huge. We are not able to provide services in the rural areas where the qualified doctors are available. That's why the things, as you say, that quacks are because our own qualified doctors are not able to reach to the community, to the masses, to the rural areas. So once I think the more and more medical colleges are coming up, more and more students who will be the doctors and they will serve the community at large. So these points are going to stay. I understand what you want to convey, but I think for another 20 to 30 years, I don't think that anyone should be scared about this thing, whether it's a corporate or the government scheme, but we have to be on our toes. We should know what is our investment, capital investment, we should have developed those financial skills and the business skills. See, it is only the medical professional skill, what we have undergone during our undergraduate post, that is not sufficient. That is only 25%, and 75% we need to have another skill like business skill, finance skill, communication skill, customer service skill, thinking analytical skill. So all these skills we have to develop to become a successful entrepreneur.
So coming to your last comments regarding the economics of the running a hospital, we have to have a good financial acumen, and otherwise, if we have a lot of help available, professional help. So what is a basic economy or financing of a medium-sized unit, you would say? See, basic rule as I understand is there has to be a debt equity ratio of 1:1 to have a successful business. So that is a general understanding, means at least you should not have a lot of debt in your whenever you start a business. So what will be your financial 4 or 5 dictums that you will follow when you plan a hospital or start a unit.
Sir, a few more minutes left. Please.
Yeah, fine. So to answer this last discussion about your Chetan, so whatever number one, see, depending upon at which stage you are, if you are starting, then definitely you will invest in the infrastructure, you will invest in the HR, you will invest in the equipment and all these things. So starting with your need, whatever the available resources, you plan it for your resources, you find a proper location where you feel you will be successful as a clinician in this area. So how many people are already practicing there? What is the quantum of work? What kind of work is going on, and accordingly plan. But I would definitely recommend that keep your initial investment low. If required for 3-4 years or 5 years, go for the rental property or lease property rather than investing in the real estates, because the real estate is very costly and it comes to a huge cost now. So better to go for a rental property and a lease property depending upon your requirement. And after 4-5 years, you can expand. At some stage, after 10 years, if you feel like you want to invest in the property, you invest. But nowadays, for any business, it is better to have a lease property or a rental property than going for an investment of that. Second thing, there are many equipment available in the market, first generation, second generation, third generation, fourth generation. So number one, any equipment which is working well in the market for last 8 to 10 years and which serve the most of the purpose, maybe 90% of the purpose, go for that kind of equipment. Don't go like I can say CT scan of 128 or 256 slide. If 16 slide CT scan works well, then why to go for 256 or 128 scan? Similarly, the MRI, and all these equipments, I think plan for the equipment which can provide a proper optimum care to the thing. So your equipment investment should be less, because every 3 to 5 years you have to change the equipment. And similarly, the HR cost, we should have an optimum. Definitely, we need the manpower like nursing or the doctors and all these things, but you should also optimize their. So what I would feel say like this. I remember Devi Septi, I heard in one of his interview, what he say, every day should be your balance sheet of the year. So what you are earning in the day and what is your expenditure of the day, the left out is your profit. So this is how you must track your finances. So what is your daily income and what is your daily expenditure? So you have to have your eye on everyday income and expenditure rather than seeing your balance sheet after 1 year and then seeing what you have won or what you have lost. So this is what I would like to say. You have to keep planning phase-wise, step-wise, depending upon the availability of the resources and all these things. Thank you.
So lastly, I think last question is now there are a lot of options available for starting a practice in the private for a new pediatrician. One has to plan a solo practice, or there may be a group practice of the same specialty. He has to join a multi-speciality, or there is a special chain of mother and child hospitals. So how do we evaluate the future of this? Very short in a few sentences.
Chetan, I think there are two things. Everything is solo, group, or working with some corporate and all these things is fine. I think you have to decide what you feel like, depending upon your own belief system, how adjustable you are, how can you adapt with the people, how can get along with the people. They may be during your postgraduation, your 3-4 friends can decide with a separate specialty like a pediatrician, gynec, medical physician, and gynecologist. They can start 4-5 people. They can start a 50-bedded nursing home. So 2-3 things with tips I would like to say. Number one, if you are going for an indoor practice, at least have a nursing home of more than 50 beds. If you are in a tier 2 and tier 1, 2 or city or 3 city, because the smaller nursing home are not viable. So if you go for a 10-bed or 15-bed, 20-bed nursing home, it will not become viable to run a 24-hour service 24/7. Because the clinical established in the act, once you become it is already in existence now. So you have to have minimum staff for minimum beds, and you have to provide 24/7 round the clock facility. So minimum 50 bed, I think you should plan. Either you can have 2 or 3 partners of the same specialty, or in different specialty you can have. So that will definitely share your expenditure also. So this is my first tip, which I would like to recommend. And then gradually you can, depending upon the work, you can expand to 50 to 100 bed and maybe above 100 bed. So this is what I would like to say.
So I think that is the key word, because solo practice, I think with these days will put lot of burden, unless we are in a extreme periphery where you cannot create a group of doctors. So I think that is a place where you can have a solo. Otherwise, mostly you should go for a group, either of the same specialty or the different specialties.
So only outdoor practice can be a solo practice. See,
Yes.
people who start just a clinic and outdoor practice, and they got attachment with some nursing home and the hospitals to admit their patient, that kind of a practice, solo practice can be.
So my last message is that, see, for all the pediatricians, the first thing is small, I'll just in 2 lines, लहरों से डरकर नौका पार नहीं होती, और कोशिश करने वालों की कभी हार नहीं होती. So keep on, doing hard work, put lot of efforts, whatever your goal is, try to achieve it. Sir, your last advice to the newcomer.
Yes, my last advice is that wherever you are in the practice, maybe after 5 years or 50 years, you need to keep updating ourselves by attending the conferences, CMEs, workshop, what new in our field. I think we have to keep updated ourselves, because ultimately it is our profession. It is we who decides how to treat the patient. So only one-sided, you keep working on the increasing the number of beds or some financial aspect. I think we have to keep updating ourselves on a regular basis, and we have to have the interest in the academics. So institutes who are having their academic programs, I think they are the more successful institute as the entrepreneurs also. All these big hospitals, they run the academic program and they survive accordingly.
Yeah, that is the biggest help when we have a big team. We get a lot of inputs from the young pediatricians who have just graduated from the hospitals with their MD degrees, and we learn a lot of things from them. So I think that's another advantage of having a team. So thank you, the organizers, and I hand over the mic to the moderator or MOC. Thank you so much. Thank you for a patient listening.
Thank you.
Thank you. I thank both Dr. Ketan and Dr. Nirmal Choraria for the wonderful, very practical and very important tips for all those who are about to practice, and also all those who are already in practice and facing many questions on this will definitely provide them with some answers. I thank both of you, sir, for being on this session. Thank you, sir.
Thank you.
With this, we go to our next and the last session of this third West Zone Mahapedicon arranged by IIT Raigad. Sepsis. As we all know, sepsis occurs when the chemicals released in the bloodstream to fight an infection trigger an inflammatory response throughout the body, which can cause a cascade of changes leading to damage to multiple organs and sometimes will cause a fatal outcome. As a result, early diagnosis and early intervention is key in such situations, and lab diagnosis, lab investigations play a very important part in this process. Without wasting much time, I would like to invite our next expert, Dr. Sonal Bangde, a very prominent pediatrician. Over to you, ma'am. Please start the session. Madam.
Yeah, thank you, Mr. Ajay. I hope I am audible.
Yes, ma'am, you are audible. You can begin your slides.
Thank you, Mahapedicon, for giving me an opportunity. First, I'll clarify I'm not a pediatrician, I'm a microbiologist. Hence, I would be talking on the laboratory diagnosis of sepsis.
Apologies, ma'am. Actually, your CV was not present, so I assume, sorry.
No issues. It's a great opportunity to be between so many pediatricians and present a view of how we look at sepsis from the laboratory point of view. So I just share my presentation. So what I would be talking about is the newer modalities, newer diagnostic modalities in sepsis, because when it comes to such parameters, it is when it comes to sepsis, people get stuck with certain number of tests, and then the situation is such that it needs a very quick diagnostic testing. So as we all know, sepsis, there are two or three main challenges which are there. The first is every minute counts. Fast treatment is critical. For every hour, there is appropriate antibiotic delay. Survival decreases by almost 7.6%. When every organism counts. So if I do give something as gram-positive organism or a gram-negative organism, the initial broad-spectrum empiric treatment is targeted to that therapy, and it is desirable. It avoids unnecessary exposure to aggressive treatments, increases the efficacy of therapy, and reduces the creation of a MDR organism. The third challenge with sepsis is every rupee counts. As I was just listening to the presentation earlier, it is also about commercials when it comes to hospitals, and decreasing the cost. Anything that is linked to use of antibiotics or intravenous antibiotics will definitely have a good outcome. So if you look at the conventional laboratory diagnosis of sepsis, it is very typically a presentation where first is when we would go in straight for biomarkers, and then a microbiological evaluation with blood culture, if suspected, or in neonates, mostly a fungal blood culture. And last, what comes as the newest modality are the molecular methods. A quick look at biomarkers. I will not go in details with biomarkers because these are very well known to most of the people. Procalcitonin is.
Sorry to interrupt, doctors.
Yeah.
Kindly stop for 5 minutes. The live link is, we are facing some technical issue with it. I'll just say in 5 minutes that we will resume after 5 minutes, please.
Sure. Okay.
Kindly stop for 5 minutes only. We regret for this inconvenience, doctors. Doctors, we can start in 1 minute, please. Am I audible, doctors?
Yeah, you're audible.
Yeah, ma'am, you're audible.
Yes, doctors, kindly start.
Madam, you can start.
Sure. Good afternoon, everyone. I think it was some small delay. I understand this is the last topic of the whole conference, so we'll go make it very crisp and clear, short in time. So I will be talking on your modalities in diagnosis of sepsis. Now, as you understand, there are 2-3 major challenges in sepsis. The first challenge is every minute counts. So fast treatment is very critical. Every hour that appropriate antibiotic is delayed, survival decreases by 7.6%. So it is the time which matters when it comes to diagnosis of sepsis, where every organism counts. So a right identification of the organism in right time helps in initiating a shifting from the initial broad spectrum empiric treatment to a target therapy, and it avoids unnecessary exposure to aggressive treatments. It also increases the efficacy of therapy and hence reducing the creation of MDR organisms. The third point, which is a challenge in diagnosis of sepsis, is every rupee counts, because by the time the patient is septic, there's a lot of hospital cost which is already incurred. So it decreases cost linked to intravenous antibiotics and oral antibiotics. That is where the laboratory diagnosis will come into picture. So if we look at the conventional way of laboratory diagnosis of looking at sepsis, the first that comes to mind is the biomarkers, and then would be along with it with the blood cultures. Now this is a standard line of going in, starting with the algorithm of diagnosis of sepsis. Now the newer methods which are come are the molecular methods in this. So I'll cover very short in with biomarkers because that's very well understood and very useful. So procalcitonin is the only FDA-approved commercially available PCT assay for a critically ill patient, and it has a very good sensitivity and specificity. Others are non-FDA approved, but they are recommended, like lactate, CRP proteins, cytokines, D-dimers, pro-ADM, and myocardial biomarkers. When it comes to microbiological diagnosis, blood cultures remain as the gold standard. But blood cultures nowadays are mostly done on automated platforms, which has a very fast detection of a rate of about 5 to 6 hours. They use special resin media so as to combat some prior antibiotic treatment, and it can also go fastidious organisms. What are the important considerations when it comes to blood culture? I think this topic is being discussed again and again many times, but it is very essential to have the right volume of blood to be given when it comes to a proper blood culture positive. So when it comes to pediatric cases, it depends on the weight of the patient. This is the optimal volume, and that is the minimal volume that is required in a one bottle of blood culture. Now, in children, we do not usually say ask for sets, but in little older children, we would really prefer 2 different sets, 1 hour apart in cases of acute sepsis. Now, does the only automated blood culture system help? Yes, it does help give a flag very positive. It gives a flag between 5 to 6 hours. But equally important is knowing the identification of the drug sensitivity, which is done by the automated identification and susceptibility systems, which gives a rapid result within 36 hours from the time of collection of sample. Now, these MIC methods are very essential so that you can assess the emerging resistance patterns and minimizing risk of right antibiotics. Now, how does automation benefit to the clinician and patient? It lowers the mortality rate because of its rapidity and accuracy. It reduces the patient time in the ICU, and rapid results help in fastest initiation of customized treatment, use of appropriate and narrow spectrum antibiotics, less toxic antibiotics, and cost effective, finally ending up with a better patient care. Now, this is a typical collection to result cycle when it comes to blood cultures. A blood culture is prescribed by a doctor, a consultant. The sample collection is done, it is transported to the laboratory, maybe a local laboratory or out of the hospital laboratory. The blood culture is, it starts processing with the blood culture. You get a gram stain report within, say, 8 to 12 hours time, and a provisional report saying gram positive or gram negative organism. Within next 48 hours, you get the whole drug sensitivity report. Now, this is what is the best available today. But are we talking about this? Even this protocol has challenges. So what are these challenges? The excellent recovery of bacteria is the winning edge in the automated blood culture, but still it has challenges. Time to appropriate microbial therapy is an independent predictor of death, and hence 48 hours is a pretty long time when it comes to getting a report. Second is, this is the time and labor intensive nature of all the traditional culture based technologies. Yes, it is a matter of frustration for most of the pediatricians when the blood culture reports, they don't get delayed, but they still take 48 hours time. And the biggest challenge is 30 to 50% of blood cultures can be negative in patients with clinically diagnosed sepsis. In cases of sepsis for bacteremia or candidemia. So these are the three challenges. So how do we overcome? So this is where our new diagnostic focus has come, which is limited, which we are saying culture limited. So we use cultures in a limited facility or culture independent technologies where you may not require to send a blood culture. So a rapid, meaningful pathogen detection for sepsis diagnosis is something that we are looking at. Now, what are the newer modalities? There could be two options. Post a blood culture bottle comes positive, you go in for some technology which will rapidly give a result. It could be a MALDI-TOF or it could be a FLIM-array like a PCID panel, or detection from directly uncultured blood samples. So I don't have to go in for a blood culture and then for identification and then for a susceptibility testing. So this is possible with multiplex real-time PCRs and a sequencing-based assays. Now, let's see at the whole result collection to result cycle in the same way. Now, this is your normal blood culture cycle, which takes 48 hours. Now, what happens when the blood culture bottle flags positive? You can go in direct identification with a MALDI-TOF, which actually takes 36 seconds only to identify an organism. Now, this is one of the latest technology which is come in India, wherein even if you consider the whole processing time from removing the bottle from the machine and trying to prepare it, it hardly takes 15 minutes time. Post which we can go in for drug resistance markers, which will take maybe some hours time. And finally, your full antibiotic report along with identification is finally ready within 12 hours. That too, considering the bottle will flag after 12 hours. It usually flags after 5 to 6 hours. So this is one way of looking at it. Now, what is this MBT sepsis titer? So this is a new technique called as MALDI-TOF, wherein when a blood culture flags positive on a BACTEC system, you can just have a small pre-processing step and put it on the MALDI-TOF and you get a direct result. So it takes around 15 minutes for the result to come. So earlier we used to call the physician saying, yes, the blood culture of this child is flagged positive and shows a gram positive organism or a gram negative organism. Nowadays, what we do is we call up and straight away say, yeah, the blood culture bottle is FLAC positive with Salmonella typhi grown in the culture, identified. So that helps into going into right treatment very soon, almost saving 15 hours than blood cultures. So what else can be done on Malditoff? We can also look for drug resistance at the same time. So you can say, yes, I have Pseudomonas aeruginosa in the blood, or any Klebsiella, and which has carbapenemase resistance. Now that gives even more filter to the physicians to choose or shift the antibiotics. Now, Malditoff is matrix associated laser deabsorption or ionization time of flight spectrometry. It's a very big name, but it is basically a mass spectrometry where you study the proteomics of the organism to give a very, very rapid result. Now, this is the usual picture of our blood cultures, which looks like we have an average positivity rate of 20% with Kleb 19%, followed by E. coli and Staph Salmonella typhi. Now, if this all organism identification comes within 8 hours, I think that is revolutionary when you look at it from the physician's point of view, because it helps the physician take the real very good call onto their treatment modalities. Now, what is the other option is to do a BCID panel, which is BioFire BCID. It has 27 targets. Now, this technology, it has its own advantages and disadvantages. It is a relatively very high cost, and the quantitative interpretation is not possible in these systems. Now, let's compare it with Malditoff with BCID panel, because people get confused on what technology should be used. Both technologies are US FDA approved. Malditoff is a matrix associated spectrophotometry, whereas BCID is a multiplex film array technique. Then the identification in Malditoff can go to species specific. So you can actually identify to the end species, whereas in BCID panel, it is usually genus specific. The number of bacteria that can be identified with Maldi goes in thousands, whereas it is only 24 in BCID panel. Time to identification is less than a minute in a Malditoff, whereas 1 hour in BCID panel. But what is most amazing is Malditoff results come in your same blood culture report. So you don't have to pay a penny more to get that identification in 8 hours time. Whereas for BCID panel, you will have to chip in something like 10 to 15,000 more for the identification. So the second option, the newer modality which we wanted to explore, was detection from uncultured blood sample. So even with this Malditoff and with BCID panels, we're trying to wait for the blood culture bottle to flag positive. So we thought to take off even that delay. So that can be taken off with the use of multiplex real-time PCR. Now PCRs is a reality of today. It is no longer anything futuristic, because post-COVID, the era is all PCR era. Now we use some technologies which are real-time nested multiplex PCR for sepsis. Now, it's very important for all of us to now get educated with the terminologies in molecular diagnostics, because there is a lot of crowd of molecular labs coming in, and we really don't know what is right and wrong between the two technologies. So real-time is a gold standard technology for PCR. That is the one which was promoted for COVID testing. It gives a quantification data, and it has a real-time quantification. So you can see the graphs as they are coming. Multiplexing the PCRs helps in detecting many number of parameters at the same time. Of course, it also increases the level of amplification, because what we do is we do a tandem multiplexing. That means you multiplex the same set of organism twice, and it is a nested PCR. So nested PCR, to be very well understood, it increases the specificity, because what we do is to identify one organism, you have two different primers at the same time. So the chances that you will get a wrong report is almost goes negligible. It increases the specificity of testing. Now, this is just explaining the nested PCR with 2 set of primers. So what's the advantage of these sepsis multiplex PCR? It has a fast result. So it's just 5 hours and the result is in the hand. So when it comes to neonatology and pediatric patients, it is very, very important to have such kind of results. What our own experience is, yes, neonates need a very fast report, and these panels are extremely useful because anyways the the volume of blood in neonates is less. You get the organisms very fast. Even the PCRs can detect it very well. Plus, you can identify all the fastidious organisms like Haemophilus and Strep pneumoniae, and all these in multiplex PCRs. You can identify candidal infections. You can rest other fungal infections and also viral infections, because when you're looking at neonates and very young children, we are looking at viral infections causing sepsis. Right? It has high sensitivity for patients previously on antibiotic. So even if the patient is given any antibiotic at some nursing home, they would damage the organism, but many a times the nucleic acid that we are looking out in molecular testing is present in the blood, and that is the reason we can detect organisms even when they are partially treated. It is very good for non-responding bacteremia and neutropenic patients. I think that is now become a norm to be used in neutropenic patients. Now, what is the performance like? These are not assays which are just made on trial basis by some research laboratories. These are CE-IVD approved assay with a specificity of 96.7% and a sensitivity of 95%. What is important when we are looking at such parameters is the negative predictive value. So if the negative predictive value is very good, you definitely know that there is no pathogen which is causing a sepsis. So it is also added advantage when it comes to looking at fevers in a neutropenic patient. Now, what all parameters are present in a sepsis panel? It usually cover up most of the gram-positive and gram-negative organism. Also the fungi at the same go. What is the amount of sample required? Just 4 ml of blood. It can go as low as 1 ml for neonates for sure. And added advantage of having some viral PCRs into this. Now we have seen so many children with CME infection. Neonates do not develop antibodies so quickly, and that is where the PCRs really come into picture, and they give very good results. It doesn't stop here. The moment you have identified an organism, you can go in for a molecular identification of resistance gene. So if you have a Klebsiella pneumoniae in a neonate, within an hour's time, you can tell it is KPC resistant. So we can interpret. Now, what we do is, as a laboratory, we would do the analysis of every resistance and put it on the report. Now, all the analysis is according to this Ambler's classification of carbapenemases, wherein say it is a KPC, you know it is resistant to carbapenems and aztreonam, but you can use colistin and tigecycline. Nowadays, the most common which is coming up is also OXA48, where you can actually use aztreonam and use colistin tigecycline or ceftazidime avibactam as an option. So all these tests have revolutionized the way you would look at sepsis henceforth. And if you look at the hospital stay or the ICU stay for 2 days versus one test of sepsis is very much less. It is definitely cost effective. Now, a short word on fungal sepsis, because nowadays we see a lot of fungal infections in children, especially neonates. Beta-D-glucan, it is the best biomarker for fungal infections, but the sensitivity increases, or the positive predictive value increases when you do it in a set at twice a week in a set. The moment you do 2 tests in a week, you definitely have a very good report. It has a huge coverage of most of the fungi. How do you use these parameters? See, it is majorly used to exclude a diagnosis of invasive fungal disease, because we do not want to give a child antifungal coverage just thinking that he may get an infection. If only this beta-D-glucan is monitored on a weekly basis, you will not need to start the child on an antifungal treatment, because it is very sensitive to pick up a invasive fungal disease. Now, it also is useful in predicting the outcome, because if you know the baseline, the values of BDG drastically drop as the patient starts responding to the antifungal treatment. We can also use standardized US FDA approved PCRSs for fungal diagnosis in children. There are some panels like invasive fungal sepsis. Now, these panels are useful for neutropenic patients and immunocompromised patients, wherein it becomes really helpful to get all the fungi onto one panel when a suspected fungal sepsis is seen. That's it from my side. It is just one message is every minute counts. Spot the sepsis as early as possible with the latest technologies that are available. Thanks a lot. Thanks for, if there are any questions, I could take that.
Thank you, ma'am. Thank you for the very wonderful and elaborate presentation on a very topic which is very important and time essential for all doctors, especially pediatricians and neurologists. I thank you on behalf of IIT Raigad for your presentation.
Yes.
Thank you, ma'am.
Thanks a lot.